Welcome to this course on multidisciplinary pain management, evidence-based update. Pain is one of the most common and disabling conditions seen in adult and older adult populations around the world. It affects physical ability, emotional health, social life, and how often people use healthcare services. In the United States alone, chronic pain affects roughly 50 million adults. Of those, about 20 million have what is known as high-impact chronic pain, meaning it significantly limits their ability to carry out daily activities. The financial costs are enormous, including both the direct costs of medical care and the indirect losses from reduced work productivity. These costs continue to climb as the population ages and more people live with multiple health conditions at once. In response, clinical evidence now supports a major shift in practice, moving away from treatments centered on opioid medications and toward comprehensive, team-based strategies that combine validated assessment, non-opioid medications, physical rehabilitation, psychological support, and newer technologies. This course is designed for the rehabilitation and healthcare professionals who work directly with patients in pain physical therapists, occupational therapists, nurses, and allied health clinicians. It addresses the clinical reality that effective pain management today requires much more than skill with a single treatment. It requires the ability to assess pain accurately across diverse patient groups, understand the basic science of how pain becomes chronic, choose evidence-based treatments that fit each patient's needs, and work effectively within a team. Older adults receive special attention throughout this course because they face unique challenges including cognitive impairment, multiple medications, fall risk, and changes in how their bodies process drugs. The content is organized into 7 evidence-based modules that build on each other. The course begins with the biological mechanisms of acute and chronic pain, establishing why multimodal treatment makes sense. It then covers comprehensive pain assessment strategies adapted for patients with different cognitive abilities and in different clinical settings, non-opioid medications with close attention to safety in older adults, physical therapy and exercise treatments with condition-specific protocols, psychological treatments and the evidence for combining physical and psychological approaches, emerging treatments including neuromodulation and digital health programs, and finally, the practical steps for bringing all of these components together in a team-based workflow with validated outcome tracking. A clinical case study module applies these concepts to realistic patient scenarios. All content reflects the most current evidence available, with the large majority of references published between 2022 and 2025, drawn from major clinical practice guidelines, systematic reviews, meta-analyses, and randomized controlled trials. This course gives clinicians the knowledge and clinical reasoning skills needed to deliver safe, effective, and patient-centered pain management. Upon successful completion of this course, you will be able to identify the key mechanisms that drive the transition from acute to chronic pain, select the appropriate validated pain assessment tool based on a patient's cognitive status, recognize the safest first-line non-opioid analgesic for a geriatric patient given their comorbidity profile, identify the most appropriate exercise or physical therapy intervention for a specific pain condition, determine which patients benefit most from combined physical and psychological pain interventions. Recognize the appropriate clinical indication for neuromodulation and digital therapeutics in pain management. And sequence the steps of a stepped care pain management model from initial assessment through escalation. Let's begin with Module 1, the Pathophysiology of Acute and Chronic Pain. A solid understanding of how pain works in the body and how it changes over time is essential for every member of the care team. This knowledge directly shapes clinical reasoning, treatment choices, and the urgency of starting multimodal treatment early. Acute pain serves a protective purpose. It alerts us to tissue damage and drives behaviors that help healing. When the injury heals, acute pain normally goes away. Chronic pain, however, is a fundamentally different condition. In chronic pain, the nervous system itself undergoes structural and functional changes that keep the pain going long after the original injury has healed. The shift from acute to chronic pain is not simply pain that lasts a long time, it involves active, identifiable biological processes that, once recognized, can be targeted with treatment. This module traces the path from the initial pain signal at the site of injury through changes in the spinal cord and brain, with special attention to the factors that make older adults and surgical patients especially vulnerable to developing chronic pain. Let's start with how the pain signal begins and travels in acute pain. Acute pain begins at the site of injury. When tissue is damaged, whether by surgery, trauma, or inflammation, specialized nerve endings called nociceptors are activated. The damaged tissue releases a mix of chemical signals including prostaglandins, bradykinin, histamine, substance P. And inflammatory proteins like tumor necrosis factor alpha or TNF alpha and interleukin 1 beta or IL-1 beta. These chemicals lower the threshold of the nociceptors, making them more sensitive to stimulation. Two types of nerve fibers carry pain signals from the injury site to the spinal cord. Thinly coated A delta fibers transmit the sharp, well-localized first pain that you feel immediately. Uncoated C fibers carry the dull, diffuse, longer-lasting second pain that follows. Both types of fibers connect to neurons in the dorsal horn of the spinal cord, where the pain signal is processed through a complex system of excitatory and inhibitory nerve cells, as well as signals descending from the brain. In the period right after surgery or injury, a process called peripheral sensitization takes over. The inflammatory chemicals surrounding the damaged tissue make the nociceptors respond more intensely than they normally would. This produces primary hyperalgesia, an exaggerated pain response to stimulation at the injury site, and sometimes allodynia, where even a light touch that would not normally cause pain is perceived as painful. It is important for clinicians to recognize that even at this early stage, psychological factors like anxiety, fear, and past pain experiences influence how much pain the patient perceives, because the brain's emotional and cognitive centers actively shape the pain experience from the top down. Normally, the intensity of acute pain corresponds to how severe the injury is, and it resolves as inflammation settles down and tissues heal. Now let's look at what happens when peripheral sensitization persists beyond the normal healing period and the role of neuroinflammation. When tissue injury is severe, when surgery involves nerve damage, or when inflammation lasts longer than the normal healing period, the peripheral nervous system can enter a state of ongoing heightened sensitivity that extends well beyond the acute phase. At the molecular level, ongoing activation of nociceptors leads to increased production of specific ion channels. Think of these as tiny gates on the nerve surface, including channels in the TRP family, particularly TRPV1 and TRPA1, and acid-sensing ion channels known as ASICs. These upregulated channels make the nerve endings even more responsive to heat, chemicals, and pressure, maintaining a stream of amplified pain signals flowing to the spinal cord. Inflammation within the nervous system itself plays a central role in sustaining this sensitized state. Immune cells, including macrophages, mast cells, and neutrophils, gather at the injury site and release inflammatory molecules that not only activate nociceptors directly, but also recruit more immune cells, creating a self-feeding cycle of inflammation and nerve sensitization. This process is especially relevant after surgery, where the extent of tissue cutting and nerve handling determines how severe and how long-lasting this neuroinflammation becomes. It is also relevant in conditions involving repeated small injuries and low-grade, ongoing inflammation, such as many musculoskeletal conditions. In older adults, age-related changes in immune function, including a tendency toward chronic low-grade inflammation throughout the body, sometimes called inflammaging, may set the stage for prolonged nerve sensitization and raise the risk of developing chronic pain. Central sensitization represents the critical turning point in the shift from acute to chronic pain. It means that neurons within the central nervous system, especially in the spinal cord and pain processing areas of the brain, become overly excitable. Once this happens, the nervous system amplifies pain signals and can even generate pain in the absence of any ongoing injury in the body. Here's how it works. The chemical messenger glutamate acts on special receptors NMDA and AMPA receptors on spinal cord neurons. Under conditions of intense or sustained pain input, NMDA receptors become activated and set off a chain reaction inside the cell. Calcium floods in, enzymes are activated, and the connections between nerve cells become permanently strengthened. This is essentially the same process the brain uses to form memories, but in this case, the spinal cord is learning to produce pain. The clinical consequences are significant. Central sensitization explains secondary hyperalgesia, where areas around the original injury become abnormally sensitive. It explains wind-up, where repeated stimulation at the same intensity produces progressively worse pain. And it explains why chronic pain often continues long after the injured tissues have healed, and why standard painkillers that target the injury site often do not work. When central sensitization shifts from a temporary, reversible state to a permanent one involving actual changes in gene expression, chronic pain becomes a disease of the nervous system itself. One of the most important discoveries in pain science over the past 2 decades is that pain is not purely a nerve cell or neuronal problem. Supporting cells in the brain and spinal cord, called glial cells, specifically microglia and astrocytes, play a major role in starting and maintaining chronic pain. When neurons are injured or sensitized, microglia become activated and release inflammatory molecules including TNF alpha, IL-1 beta, interleukin 6 or IL-6, and chemokines like CCL2. These molecules act directly on spinal cord neurons to boost pain signaling and maintain central sensitization. Astrocytes, which become activated a bit later than microglia, contribute to ongoing chronic pain by releasing glutamate and other chemicals that keep neurons in a hyperexcitable state. The two-way communication between neurons and glial cells, called neuroimmune crosstalk, creates a feed-forward loop. Nerve activity triggers glial activation, and glial chemicals amplify nerve signaling. This mechanism helps explain why chronic pain states tend to be self-sustaining, and why effective treatment needs to target not just nerve pathways but also the inflammatory and immune components of pain. In older adults, age-related changes in glial cell function and immune regulation may further increase vulnerability to chronic pain. Beyond the spinal cord, chronic pain involves significant changes in the brain itself. Brain imaging studies have shown that persistent pain causes reorganization of brain maps, reductions in gray matter volume, and disrupted communication among key pain processing regions, including the prefrontal cortex, anterior cingulate cortex, insula, amygdala, and thalamus. In effect, the brain rewires itself around the pain experience, embedding it into persistent network states that resist standard pain treatments and that can affect thinking, emotion, and behavior independently of anything happening in the body. Epigenetic changes add another layer of complexity. These are chemical modifications such as DNA methylation, histone acetylation, and microRNA activity that turn genes on or off without changing the DNA sequence itself. In chronic pain, epigenetic modifications can alter the expression of genes involved in pain processing, including genes for sodium channels known as SCN9A, brain-derived neurotrophic factor or BDNF, and opioid receptors. These changes can be triggered by intense pain, psychological stress, or inflammatory signals, and they may create a lasting predisposition to chronic pain that persists even after the original trigger is gone. The concept of maladaptive neuroplasticity, the nervous system changing in ways that harm rather than help the patient, underscores the importance of treating pain aggressively and early, before central sensitization and brain reorganization become entrenched. Let's now turn to the risk factors for chronic postsurgical pain, or CPSP pain that persists beyond the expected healing period, typically 3 months or more. CPSP affects a substantial number of surgical patients and represents one of the most clinically important examples of the acute to chronic pain transition. The risk factors span biological, psychological, and procedural categories. The extent of nerve injury during surgery is among the strongest predictors, because direct nerve damage sets off the cascade of peripheral sensitization, neuroinflammation, and central sensitization described earlier. The severity and duration of acute pain after surgery have also been consistently identified as independent risk factors, which supports the clinical rationale for aggressive multimodal pain control in the perioperative period. Genetic factors contribute to differences between individuals. Variations in genes that encode catechol-O-methyltransferase, or COMT, the mu-opioid receptor known as OPRM1, and GTP cyclohydrolase 1, or GCH1, have been linked to altered pain sensitivity and higher risk of CPSP. Psychological factors, including preoperative anxiety, depression, pain catastrophizing, which is a pattern of rumination, magnification, and helplessness about pain, and fear avoidance beliefs, amplify pain perception through their effects on stress hormones and on the brain's ability to suppress pain signals. Conditions like pre-existing chronic pain, sleep problems, and obesity also increase risk. Trauma patients are particularly vulnerable because of the unpredictable nature of their injuries combined with the psychological distress that typically accompanies traumatic events. Older adults present unique pain management challenges rooted in changes across multiple body systems. Let's look at these age-related changes and their implications. Peripheral nerve function declines with age. There are fewer nerve fibers, they conduct signals more slowly, and certain pain receptors are less abundant. Paradoxically, rather than reducing pain sensitivity, these changes can alter the character of pain, leading to delayed awareness of pain, difficulty pinpointing where the pain is coming from, and a reduced ability to tell the difference between harmful and harmless stimuli. In the central nervous system, the body's natural pain suppression systems become less efficient with age. The descending pathways that normally dampen pain signals using chemical messengers like serotonin, norepinephrine, and the body's own opioids show reduced activity, meaning the spinal cord has less ability to filter out pain signals. The combination of peripheral nerve changes and weakened central pain control means older adults may experience persistent pain from injuries or conditions that would resolve more quickly in younger patients. Age-related declines in the nervous system's ability to repair and adapt can also lock in maladaptive pain states. The psychosocial dimensions of pain in older adults are equally important. Social isolation, loss of independence, cognitive decline, depression, and accumulated life stress all contribute to the pain experience and influence how well treatment works. These factors, combined with the biological vulnerabilities described above, make a strong case for a biopsychosocial approach to geriatric pain management, one that brings together medication, rehabilitation, psychological support, and social interventions tailored to each patient's physiological profile and life circumstances. Let's wrap up Module 1 by connecting these mechanisms directly to clinical practice. The mechanisms outlined in this module have direct and immediate clinical implications. Because pain chronification involves peripheral sensitization, central sensitization, glial activation, maladaptive neuroplasticity, and psychosocial amplification, multiple processes operating simultaneously, treatment must address multiple targets at once rather than relying on any single medication. Early multimodal interventions that combine anti-inflammatory agents to target peripheral sensitization, adjuvant medications to dampen central sensitization, physical therapy to restore function and counter deconditioning, and psychological interventions to address catastrophizing and emotional distress offer the best chance of preventing the transition from acute to chronic pain. For the multidisciplinary team, this means that every professional is intervening at a different but complementary point along the biological chain that drives pain persistence. The nurse performing the initial pain assessment, the physical therapist prescribing an exercise program, the occupational therapist modifying activities to reduce joint stress, and the psychologist delivering cognitive behavioral therapy each addresses a distinct piece of the puzzle. The remaining modules of this course translate this scientific foundation into the specific assessment strategies, medication protocols, rehabilitation techniques, and psychological interventions that make up contemporary, evidence-based pain management. We now move to Module 2, Validated Pain Assessment Across Populations. Accurate, reliable pain assessment is the foundation on which all treatment decisions rest. Without a clear understanding of a patient's pain, its intensity, character, impact on function, and how it changes over time, even the best intervention cannot be properly targeted, adjusted, or evaluated. This module provides a thorough review of validated pain assessment tools for adult and older adult populations, organized by cognitive status and clinical setting, with practical guidance on how to choose the right tool within a team-based care model. Let's begin with self-report tools for cognitively intact adults and older adults. Self-report is the gold standard for pain assessment when the patient has the cognitive ability to communicate their pain experience. Among single-dimension scales, the Numeric Rating Scale, or NRS, has the most evidence supporting its validity, reliability, and ability to detect change in chronic musculoskeletal pain populations. The NRS asks patients to rate their pain from 0, meaning no pain, to 10, meaning worst pain imaginable. It is widely favored in clinical practice because it is simple, quick to administer, and sensitive to treatment effects. A 30% reduction from baseline on the NRS is generally accepted as a clinically meaningful improvement, making it a useful benchmark for evaluating treatment response. The Visual Analog Scale, or VAS, a 100mm line on which the patient marks a point, has similar properties but carries a much higher error rate, approaching 20% among older adults, which is why current guidelines recommend the NRS over the VAS for geriatric populations. The Defense and Veterans Pain Rating Scale, or DVPRS, adds descriptive words and visual anchors to numeric ratings, improving understanding for patients with varying levels of health literacy. For patients with musculoskeletal pain, particularly low back pain, osteoarthritis, and trauma-related pain, a single pain intensity number captures only one piece of a complex puzzle. The Brief Pain Inventory, or BPI, fills this gap by measuring both pain intensity and how much pain interferes with daily function, including activity, walking, work, mood, sleep, enjoyment of life, and relationships. The BPI is the only general multidimensional pain tool validated specifically for low back pain, and its interference subscale gives clinicians critical information about how pain affects the patient's ability to participate in rehabilitation and daily life. An interesting finding from the research is that older adults actually rate multidimensional scales like the BPI and Pain Detect as significantly easier to use than simpler scales like the NRS and VAS. However, low mini-mental state examination, or MMSE, scores predict difficulty with the Pain Detect, highlighting the importance of screening cognitive function before choosing an assessment tool for older patients. Among condition-specific disability measures, the Oswestry Disability Index, or ODI, and the Roland-Morris Disability Questionnaire, or RMDQ, have both shown excellent properties for patients with low back pain. A detailed comparison study of 214 older adults found that both tools had good internal consistency with Cronbach's alpha of 0.86 for the ODI and 0.89 for the RMDQ adequate test retest reliability, with intra-class correlation coefficients of 0.89 and 0.85 and similar ability to detect change. The RMDQ uses a minimally important difference of 2.5 to 5 points, while the ODI uses a threshold of 10 points or a 30% reduction from baseline. The Quebec Back Pain Disability Scale, or QBPDS, a 20-item measure with a minimally important difference of 30% reduction from baseline, offers another option with high internal consistency alpha of 0.94 and is equally appropriate for older adults. Clinicians should choose the tool that fits their practice setting and patient population, recognizing that all three are top-rated recommendations for older adults with non-specific low back pain. Now let's discuss adaptations for patients with mild to moderate cognitive impairment. Cognitive impairment does not automatically mean a patient cannot self-report pain. For patients with mild to moderate cognitive impairment, self-report remains possible and should always be attempted first. However, certain adjustments help improve reliability, allowing extra response time, simplifying and rephrasing questions as needed, using enlarged font and improved lighting, and reducing distractions during assessment. The horizontal 21-point box scale, ranging from 0 to 100, has shown the best measurement properties in this group and is recommended for reliable pain intensity ratings. Clinicians should be aware that the reliability of self-reported pain varies depending on what time frame is being assessed. Retrospective estimates of usual and worse pain tend to be more reliable in cognitively impaired patients, while usual and least pain estimates are more reliable in people without cognitive impairment. Completion rates for the NRS drop as cognitive impairment worsens. About 75.5% of patients with mild impairment and 57.5% with moderate impairment can successfully complete the NRS. When a patient's cognitive status is uncertain, brief screening with the MMSE or a similar tool can guide assessment decisions and identify patients who may need observational approaches. For patients with severe cognitive impairment, advanced dementia, or inability to communicate verbally, observational pain assessment tools are essential. The American College of Surgeons and international guidelines recommend a step-by-step approach. First, try self-report using simplified methods. Second, systematically look for potential causes of pain. Third, observe and document pain-related behaviors such as guarding, grimacing, rubbing, agitated movements, and vocalizations. And fourth, ask family members and caregivers about the patient's typical behavioral patterns. Among validated observational tools, the Pain Assessment in Advanced Dementia Scale, known as PAIN-AD, has the broadest evidence base. It evaluates 5 behavioral areas: breathing pattern, negative vocalization, facial expression, body language, and consolability, each scored from 0 to 2, producing a total score of 0 to 10. The PAIN-AD has good construct validity, high internal consistency with Cronbach's alpha of 0.69 to 0.74, and demonstrated sensitivity to pain treatment, meaning scores reliably decrease when effective treatment is provided. It is recommended by both the American College of Surgeons and UK National Guidelines for post-surgical trauma and dementia care settings. The Pain Assessment Checklist for seniors with limited ability to communicate, known as PACSLAC, and its refined version PACSLAC 2, provides a broader assessment covering facial, body, vocal, activity, and mood domains. In direct comparisons, the PACSLAC received the highest rating for clinical usefulness from nursing staff and shows high reliability with Cronbach's alpha above 0.80 point. Notably, the PACSLAC detected pain in 27.1% of cases where the clinical team alone found no pain behaviors, highlighting the value of using standardized tools rather than relying solely on clinical judgment. Other validated tools include the Dolo Plus 2 scale, which evaluates physical reactions, movement responses, and psychosocial behaviors. The MOBID 2 pain scale, developed specifically for advanced dementia and uniquely designed to detect both musculoskeletal and internal organ pain through standardized movement procedures. The ABBY pain scale, notable for simplicity and ease of use in dementia care, and the Pain Assessment in Impaired Cognition Scale, or PAIC-15, a consensus-based tool combining the strongest items from multiple existing scales. Now let's address functional pain assessment in patients with multiple health conditions. Older patients with multiple health conditions present special assessment challenges because pain frequently interacts with and is worsened by conditions like osteoarthritis, neuropathy, cardiovascular disease, and depression. In this population, assessing pain in isolation from function gives an incomplete clinical picture. The functional pain scale addresses this by evaluating pain in the context of the patient's ability to perform activities and participate in daily life, making it especially appropriate for complex geriatric patients where the treatment goal is not just pain reduction but preserving or restoring functional independence. For patients with low back pain, the ODI, RMDQ, and QBPD-SH assess disability from the patient's perspective and have been validated for older adults. Assessing pain both at rest and during movement is an important clinical distinction. Rest pain reflects comfort and sleep quality, while movement pain reflects the patient's ability to participate in rehabilitation and may predict the risk of complications like deconditioning from immobility. Physical performance tests, including the timed up and go test and the 5-repetition sit to stand test, provide objective measures that complement patient-reported outcomes and have moderate to strong evidence for reliability and validity in older adults with low back pain. The choice of assessment tool should also be guided by whether the pain is acute or chronic. In acute settings such as the immediate post-surgical or post-trauma period simple, quick tools like the NRS and VAS are typically most appropriate because they can be administered repeatedly and easily. The short-form McGill Pain Questionnaire-2 or SFMPQ2 and the clinically aligned pain assessment known as CAPA have also shown reliability in acute pain settings. Frequent reassessment is essential in acute care to track treatment response, detect complications, and guide medication adjustments. For chronic pain, multidimensional assessment becomes essential. Capturing pain-related functional limitations, psychological distress, sleep disruption, and quality of life provides the comprehensive picture needed to design and evaluate multimodal treatment plans. Core outcome domains recommended by international consensus include pain intensity measured by the NRS, pain interference measured by the BPI or PROMIS pain interference, physical function measured by the ODI, RMDQ or PROMIS physical function, psychological well-being measured by the PHQ-2 or PHQ-9 and GAD-2, and patient global impression of change or PGIC. These domains and their instruments are discussed in detail in Module 7. Let's conclude Module 2 with a look at implementation, the team roles, electronic health record integration, and training needed to make pain assessment work in practice. Effective pain assessment is a team effort. In most clinical settings, nurses perform the initial pain screening, choosing tools based on the patient's cognitive status and administering them as part of routine assessment. Physical therapists and occupational therapists incorporate pain assessment into their evaluations and treatment sessions, using both patient-reported and performance-based measures to track functional progress and adjust therapy. Psychologists assess the psychological dimensions of pain using validated tools for catastrophizing, anxiety, and depression. Electronic health record systems should be set up to prompt regular pain assessments using standardized tools, record scores in a format that allows tracking over time, and facilitate communication across disciplines. Training staff across all disciplines in the selection, administration, and interpretation of pain assessment tools is essential for consistent, reliable assessment and for building a shared clinical language around pain management goals. Family and caregiver input should be systematically requested and documented, particularly for patients with cognitive impairment, as caregivers often notice subtle behavioral changes that clinicians may miss during brief encounters. Welcome to Module 3, Non-Opioid Pharmacologic Management. Non-opioid medications form a critical pillar of multimodal pain management in adult and older adult populations. The 2022 CD Clinical Practice Guideline, the American College of Physicians and American Academy of Family Physicians Guidelines, the American Geriatric Society Beers Criteria 2023 Update, and the American Academy of Family Physicians all provide consistent evidence-based recommendations that prioritize non-opioid agents as first-line treatment for most acute and chronic pain conditions. This module reviews the comparative effectiveness and safety of each major non-opioid drug class, organized by clinical indication, with special emphasis on the safety considerations that drive prescribing decisions in older adults, including fall risk, cognitive effects, multiple medications, and organ function. Let's start with topical NSAIDs, which are first line for localized musculoskeletal pain. Topical nonsteroidal anti-inflammatory drugs, or NSAIDs, have the most favorable balance of benefit and harm for localized musculoskeletal pain across all adult age groups. For acute musculoskeletal injuries that do not involve the low back sprains, strains, and contusions, topical diclofenac gel achieves a number needed to treat, or NNT, of 1.8, meaning fewer than 2 patients need to be treated for one to achieve at least 50% pain relief. This is an exceptionally strong efficacy signal. Other topical NSAID formulations show NNTs of 2.5 for ketoprofen gel and 3.9 for ibuprofen gel. High certainty evidence shows that topical NSAIDs are among the most effective treatments for patient satisfaction, and moderate certainty evidence supports their superiority for functional improvement in acute musculoskeletal injuries. The American College of Physicians and American Academy of Family Physicians guidelines recommend topical NSAIDs with or without menthol gel as first-line treatment for acute non-low back musculoskeletal injuries. For chronic musculoskeletal conditions, particularly knee and hand osteoarthritis, topical diclofenac achieves NNTs of 5.0 at less than 6 weeks and 9.8 at 6 to 12 weeks, confirming sustained effectiveness. The advantage of topical NSAIDs for localized osteoarthritis rests not only on pain relief but also on their excellent safety profile. In a pooled analysis of 42 studies involving 6,740 participants with acute pain, topical NSAID-treated patients experienced side effects at a rate of 4.3%, which was statistically the same as the placebo rate of 4.6%. Real-world data from a matched study of over 22,000 patients per group showed that topical NSAIDs were associated with lower risks of death with a hazard ratio of 0.59, cardiovascular disease with a hazard ratio of 0.73, and gastrointestinal bleeding with a hazard ratio of 0.53 compared with oral acetaminophen during 1 year of follow-up. The American Geriatric Society specifically endorses topical NSAIDs as an alternative to long-term oral NSAIDs, and the 2023 Beers criteria supports this recommendation. Now let's look at oral NSAIDs, their effectiveness, and the specific risk management considerations for geriatric patients. Oral NSAIDs have strong evidence for pain relief in acute and chronic musculoskeletal conditions, including low back pain, osteoarthritis, and post-surgical and trauma-related pain. For acute musculoskeletal injuries, moderate certainty evidence supports small pain reductions with oral NSAIDs. For chronic low back pain, low certainty evidence shows small improvements in pain and disability. The CDC guideline recommends NSAIDs as first-line medication for patients with chronic pain who have not responded adequately to non-drug approaches and who do not have contraindications. For acute low back pain, NSAIDs have been shown to be more effective than opioids for dental surgical pain, similarly effective for low back pain, and comparably effective for kidney stone pain, reinforcing the principle that opioids should not be first-line agents. However, the risk profile of oral NSAIDs in older adults demands careful management. The primary concerns include gastrointestinal bleeding, cardiovascular events including heart attack and stroke, kidney impairment, and interference with the cardioprotective effects of low-dose aspirin. The 2023 Beers criteria recommends avoiding non-COX-2 selective oral NSAIDs for chronic use and avoiding short-term scheduled use combined with systemic corticosteroids, anticoagulants, or antiplatelet agents unless alternatives have failed and stomach protection with a proton pump inhibitor is provided. When oral NSAIDs are clinically necessary, they should be prescribed at the lowest effective dose for the shortest duration, and they should be avoided entirely in patients with kidney insufficiency, active upper gastrointestinal bleeding, platelet disorders, heart failure, low sodium, low blood volume, or liver impairment. COX-2 selective inhibitors, such as celecoxib, may be considered in patients at elevated gastrointestinal risk but require concurrent cardiovascular risk assessment. Oral NSAIDs are also associated with falls requiring medical treatment in older adults, likely because of an increased probability of bleeding events rather than direct effects on balance or thinking. A large nationwide study of Medicare patients showed that patients discharged from the hospital on opioids had a higher relative risk of falls or fractures compared to those receiving NSAIDs alone, 4.5% versus 3.4%, with a relative risk of 1.3, suggesting that while oral NSAIDs carry fall risk, opioids are even more dangerous in this regard. Let's discuss acetaminophen and its revised role in pain management. Acetaminophen has long been considered a basic pain medication, but accumulating evidence has significantly narrowed when it should be used. For chronic low back pain, high-certainty evidence from Cochrane reviews shows no significant benefit of acetaminophen over placebo for either pain or disability. For osteoarthritis, acetaminophen is no longer considered first-line due to limited evidence of effectiveness, and both the CDC guideline and the American Academy of Family Physicians recommend prioritizing NSAIDs and duloxetine instead. In acute settings, acetaminophen provides modest pain relief for mild to moderate pain and works best when given on a schedule rather than as needed. Despite its limited effectiveness for chronic conditions, acetaminophen remains clinically important because of its favorable safety profile regarding falls and cognition. Unlike NSAIDs, gabapentinoids, and SNRIs, acetaminophen is not associated with increased fall risk through sedation, blood pressure drops, or cognitive effects, making it the safest first-line option from a fall prevention standpoint. However, the body clears acetaminophen more slowly with age, requiring dose reduction. The maximum daily dose should be limited to 2,000 milligrams for patients over 80 years of age, with further reductions for those at increased risk due to heavy alcohol use, low body weight, malnutrition, liver problems, or fever. The serotonin norepinephrine reuptake inhibitors, or SNRIs, particularly duloxetine and venlafaxine, have become important agents for both neuropathic and musculoskeletal pain. For neuropathic pain conditions, including postherpetic neuralgia and diabetic peripheral neuropathy, SNRIs show a number needed to treat of 6.4 for achieving 50% pain relief. Duloxetine has shown particular effectiveness in adults over 65 and in knee osteoarthritis specifically, with small to moderate benefits for pain and function. The American Geriatric Society recommends SNRIs as the preferred alternative to older tricyclic antidepressants for nerve pain in older adults, given that SNRIs have a much more favorable safety profile with respect to anticholinergic side effects, cardiovascular risks, and cognitive effects. Duloxetine is typically started at 30 milligrams daily and increased to 60 milligrams daily based on tolerability and response. Despite its advantages over tricyclic antidepressants, duloxetine is not without risk in older populations. It is associated with moderate to large increases in nausea and dose-related sedation, and it is listed in the Beers criteria as requiring caution in older adults with a history of falls. A landmark 2025 study of 57,086 older adults with neuropathic pain produced an unexpected finding. Duloxetine users had nearly twice the rate of fall-related healthcare visits compared to gabapentin users, 158.21 versus 84.44 per 1,000 person years at 180 days, although there was no difference in severe falls, including hip fracture or falls requiring emergency care or hospitalization. This finding challenges the conventional assumption that duloxetine is uniformly safer than gabapentinoids for fall risk and underscores the importance of individualized risk-benefit assessment. Now let's cover gabapentinoids and their use for neuropathic pain with appropriate caution. Gabapentin and pregabalin remain important treatments for neuropathic pain, with numbers needed to treat ranging from 2.9 to 7.7 for conditions including postherpetic neuralgia and diabetic peripheral neuropathy. However, their use in older adults requires particular caution. The CDC guideline notes that gabapentinoids are associated with large increases in confusion, dizziness, blurred vision, sedation, and weight gain, with a moderate increased risk of discontinuation due to side effects. The 2023 Beers criteria lists gabapentinoids as medications requiring caution in older adults with a history of falls. A critical clinical point is that gabapentinoids should be avoided for chronic low back pain, where they show no benefit and carry risk of side effects. This is an important distinction from neuropathic pain, where they are effective. When gabapentinoids are prescribed for appropriate neuropathic conditions in older adults, slow dose increases to the lowest effective dose are essential, and combining them with opioids or benzodiazepines should be avoided except during carefully supervised medication changes due to the substantially increased risk of sedation, respiratory depression, and falls. The 2025 study referenced earlier adds important perspective. When gabapentin was compared directly to duloxetine in the same population of older adults with neuropathic pain, gabapentin users had a significantly lower rate of fall-related visits with a hazard ratio of 0.52. This finding suggests that the fall risk associated with gabapentinoids may be lower than previously assumed when compared to other centrally acting pain medications, though both classes remain higher risk than topical agents. Topical agents for neuropathic pain offer localized pain relief with minimal absorption into the body, making them particularly attractive for older adults taking multiple medications. The high-concentration capsaicin 8% patch achieves a number needed to treat of 10.6 for neuropathic pain, while lidocaine 5% patches show a number needed to treat of 4.4. Both agents are recommended by the CDC and the American Geriatric Society for localized neuropathic pain and can be used alone or in combination with systemic medications for patients who cannot tolerate oral drugs. Menthol-containing ointments and rubefacients, or warming agents, are also endorsed for localized musculoskeletal pain and provide additional topical options with favorable safety profiles. Several medication classes should be avoided or used with extreme caution in older adults. Let's review these important safety boundaries. Tricyclic antidepressants, despite their historical use for neuropathic pain, are essentially off-limits in geriatric populations due to their anticholinergic effects, including cognitive impairment, urinary retention, and constipation, cardiovascular risks, including blood pressure drops and heart rhythm problems, and increased fall risk. Skeletal muscle relaxants carry significant anticholinergic effects and moderate increased risk of side effects and should be avoided in older adults. Chronic use of non-selective oral NSAIDs without stomach protection is also discouraged. The landmark SPACE trial provides the definitive evidence against routine opioid use. In a 12-month randomized comparison of opioid versus non-opioid medications for chronic back pain or hip and knee osteoarthritis, opioid therapy was not superior to non-opioid therapy for pain-related function and was associated with more side effects. This trial, combined with the well-documented risks of opioid use in older adults, including falls, cognitive impairment, respiratory depression, constipation, and potential for misuse, supports making non-opioid strategies the priority throughout the pain management process. Let's bring this all together with a practical guide to choosing medications by pain condition. In clinical practice, medication selection should be guided by the specific pain condition, the patient's age and health profile, and the balance of effectiveness against safety. For localized osteoarthritis of the knee or hand, topical NSAIDs are first line, followed by oral NSAIDs with stomach protection if needed and duloxetine, which shows particular effectiveness in older adults and in knee osteoarthritis. For chronic low back pain, oral NSAIDs and duloxetine are recommended for patients without contraindications who have not responded adequately to non-drug approaches. Gabapentinoids should be avoided for this condition. For neuropathic pain, SNRIs and gabapentinoids are first-line systemic agents, with topical lidocaine and capsaicin as alternatives for localized conditions. For acute musculoskeletal injuries, topical NSAIDs with or without menthol gel are first-line, with oral NSAIDs and scheduled acetaminophen as appropriate alternatives. Throughout all of these recommendations, the principles of starting at low doses, increasing slowly, monitoring for side effects, particularly falls, sedation, cognitive changes, gastrointestinal symptoms, and kidney function, and integrating medications within a broader multimodal strategy remain paramount. Welcome to Module 4, Physical Therapy and Exercise Interventions. Physical therapy and exercise-based treatments are among the most well-supported and broadly applicable components of multidisciplinary pain management. Recommended by every major clinical practice guideline, including those from the CDC, the American College of Physicians, the American Academy of Pain Medicine, and the American Psychological Association, exercise therapy, manual therapy, neuromodulation, and mind-body practices offer effective, low-risk options for pain reduction and functional restoration across musculoskeletal, neuropathic, and post-surgical conditions. This module reviews the evidence for each approach, provides condition-specific recommendations, and details practical protocols including transcutaneous electrical nerve stimulation parameters that rehabilitation professionals can apply directly in practice. Exercise is the single most broadly recommended non-pharmacologic treatment for chronic pain. Let's look at the evidence in detail. A comprehensive evidence review encompassing 21 Cochrane reviews containing 381 primary studies and 37,143 participants concluded that exercise is more beneficial for improving function, with strong evidence for a small effect, than for direct pain relief where the evidence is conflicting for a small effect. High-quality evidence shows that exercise therapy for chronic low back pain, fibromyalgia, and hip or knee osteoarthritis reduces pain and improves function immediately after treatment, with improvements lasting at least 2 to 6 months. A critical finding across the research is that no single exercise program is clearly better than others. Programs should therefore be tailored to the individual patient's pain condition, physical capacity, preferences, and goals. The American Academy of Family Physicians recommends that patients do the type of low-impact exercise they prefer, recognizing that patient preference and long-term adherence are the main drivers of outcomes. Specific exercise types and their indications include low-level aerobic exercise for fibromyalgia, strength training for back pain associated with deconditioning, flexibility training for arthritis and trigger points, and balance training for patients with pain-induced weakness at risk for falls. Exercise shows greater benefit for musculoskeletal and widespread pain than for neuropathic pain, though it has been used successfully across the pain spectrum. For chronic low back pain, the most extensively studied condition, good evidence supports exercise therapy with moderate effect sizes, averaging 10 to 20 points of improvement on a 100-point pain scale, or 2 to 4 points on the Roland-Morris Disability Questionnaire. For hip osteoarthritis, the American Psychological Association conditionally recommends exercise over usual care. For knee osteoarthritis, mind-body therapies show low-strength evidence for moderate improvement in pain and small improvement in function. In older adults specifically, low-impact and balance-focused exercise programs should be prioritized to accommodate other health conditions and to reduce fall risk while still achieving the pain-relieving and functional benefits of physical activity. Now let's discuss manual therapy approaches, including spinal manipulation and massage, as well as acupuncture. Manual therapies, including spinal manipulation and massage, provide small to moderate benefits for chronic low back pain, chronic neck pain, osteoarthritis, and fibromyalgia. The American College of Physicians supports spinal manipulation as a treatment option for both acute and chronic low back pain, with moderate effectiveness documented in chronic cases. The American Psychological Association conditionally recommends spinal manipulation for short and intermediate term management of chronic low back pain. For neck pain, acupuncture is conditionally recommended over sham or usual care for short and intermediate term pain relief, along with exercise and spinal manipulation. Massage and myofascial release therapies produce small improvements in pain and function across chronic musculoskeletal conditions, but are generally less effective than structured exercise programs. Clinicians should view manual therapies as valuable additions within a multimodal program rather than as standalone treatments, recognizing that their effects are typically greatest when combined with active exercise and patient education. Acupuncture has accumulated moderate quality evidence for small to moderate improvements in pain and function in chronic low back pain, fibromyalgia, and knee osteoarthritis, with a favorable safety profile that includes minimal risk of serious adverse events. The American College of Physicians and American Psychological Association both include acupuncture in their recommended treatment options for chronic pain. For clinicians and patients open to this approach, acupuncture represents a reasonable component of a multidisciplinary plan, particularly when other conservative treatments have not provided enough relief. Mind-body interventions including yoga, tai chi, qigong, and mindfulness-based stress reduction or MBSR are supported by moderate evidence for chronic low back pain and osteoarthritis, with moderate effects on pain and small effects on function. These therapies are particularly well suited for older adults because they combine gentle physical activity with relaxation and attention training, addressing both the physical and psychological aspects of pain without the risks associated with high-intensity exercise or medications. A randomized clinical trial published in JAMA Internal Medicine showed significant improvement in global impression of change with a mind-body program in older adults with chronic low back pain, providing direct evidence of their clinical value in this population. Now let's turn to transcutaneous electrical nerve stimulation, or TENS, its protocols, evidence, and application in geriatric populations. TENS is a non-invasive electrical stimulation technique that continues to play an important role in pain management, particularly for patients who cannot tolerate medications. The largest meta-analysis to date, covering 381 randomized controlled trials and 24,532 participants, found moderate certainty evidence that pain intensity is lower during or immediately after TENS compared to placebo. However, the evidence is mixed for sustained pain relief beyond the stimulation period, and results vary by condition. Stimulation intensity is the most important factor determining whether TENS works. A meta-analysis of fibromyalgia trials showed that intensity was significantly associated with effect sizes. High-intensity application produced meaningful pain relief, while low-intensity application was ineffective. The key clinical principle is to achieve a strong but comfortable stimulation, with current amplitude typically above 15 milliamps, so that the patient feels a definite, strong tingling sensation without pain. Intensity should be increased during the session to maintain the stimulation as the nerves accommodate. Two main TENS modes have different mechanisms and clinical uses. Conventional high-frequency TENS at 50 to 100 Hz at low to moderate intensity preferentially activates large nerve fibers and spinal opioid receptors, producing the best pain relief when electrodes are placed in the same area as the pain. Acupuncture-like low-frequency TENS at 2 to 4 Hz at higher intensity activates different nerve fibers and opioid receptors, producing more widespread pain relief with potentially longer-lasting effects. Session duration should generally be 30 to 60 minutes, with at least 10 sessions recommended for chronic conditions based on findings that the number of sessions is significantly associated with treatment effect sizes. Electrodes are placed on the skin over or around the painful area, with specific placement varying by condition. For older adults specifically, a 2025 randomized controlled trial of 126 participants with early to mild knee osteoarthritis showed that TENS combined with home exercise significantly decreased pain during activity compared to sham TENS plus exercise, with additional benefits for knee strength. The combination of TENS with exercise shows stronger evidence than TENS alone in older adults, reinforcing the multimodal principle. TENS has minimal side effects limited to occasional skin irritation at electrode sites, and critically, it has no drug interactions and no body-wide side effects, making it especially valuable for frail older adults taking multiple medications. Contraindications include cardiac pacemakers or implantable defibrillators, and TENS should not be applied over areas with vascular, neurologic, or skin compromise. For knee osteoarthritis, the evidence is inconsistent. While a 2022 meta analysis of 14 studies found that active TENS showed greater improvement in pain than sham, a large multicenter trial of 220 participants found no difference between TENS and placebo TENS at 3 weeks. This inconsistency suggests that TENS may work best as an addition to exercise rather than as a standalone treatment for osteoarthritis, consistent with the positive results from the 2025 trial combining TENS with home exercise. Integrating physical therapy, psychological treatment, and patient education within a structured multidisciplinary rehabilitation program yields moderate improvements in pain and small improvements in function for chronic low back pain and fibromyalgia. The American College of Physicians endorses multidisciplinary rehabilitation as a recommended approach, acknowledging that while the evidence quality is variable, these comprehensive programs address the biopsychosocial complexity of chronic pain more effectively than any single treatment. Multidisciplinary rehabilitation is discussed further in the modules on combined physical psychological approaches and team-based care. Let's close Module 4 with guidance on managing acute pain through activity and other non-pharmacologic approaches. For acute pain, particularly acute low back pain, the evidence supports a clear clinical message. Patients should be advised to stay active rather than rest. Bed rest has been shown to delay recovery, while maintaining normal activity produces small reductions in pain and functional improvements. Superficial heat is the only non-pharmacologic therapy with good evidence for moderate benefit in acute low back pain, and it can be recommended as a safe, accessible addition to medication and activity modification in the acute phase. Welcome to Module 5, Psychological Interventions and Combined Approaches. The biopsychosocial model of pain recognizes that psychological factors, including thoughts, emotions, behaviors, and social circumstances, are not merely consequences of pain, but active contributors to its severity, persistence, and impact on function. Psychological interventions, most notably cognitive behavioral therapy, or CBT, have an established evidence base showing clinically meaningful benefits for pain, disability, and psychological distress across a range of chronic pain conditions. Perhaps more importantly, recent high-quality trials have clarified when and for whom psychological interventions provide the greatest benefit, particularly when combined with physical therapy and rehabilitation. This module examines the evidence for specific psychological approaches, the advantage of combined physical-psychological treatments over single treatments, how to identify patients most likely to benefit, and the important role of timing and delivery method. Let's begin with cognitive behavioral therapy for chronic pain, the most extensively studied psychological treatment and the only approach with consistently positive evidence across multiple systematic reviews. A Cochrane review found that CBT provides small but statistically significant benefits for pain, disability, and distress in the short term when compared to usual treatment. These effects, while modest in size, are clinically meaningful when considered alongside CBT's excellent safety profile and the limited effectiveness of many medications for chronic pain. The best candidates for CBT are motivated individuals with clear treatment goals and coexisting mood or anxiety disorders that amplify the pain experience. A strong therapeutic relationship between patient and provider is crucial for maximizing CBT effectiveness. Any member of the multidisciplinary team may incorporate CBT principles, such as cognitive restructuring, which means changing unhelpful thought patterns, behavioral activation, graded activity, relaxation training, and pain coping skills into their clinical interactions. Group-based CBT may offer additional advantages through peer support, giving patients the opportunity to learn from others' experiences and reducing the isolation that frequently accompanies chronic pain. For chronic low back pain specifically, a network meta-analysis found that CBT combined with physiotherapy produces clinically important improvements in physical function, with a standardized mean difference of 1.01 at the end of treatment, supported by moderate quality evidence. The most sustainable effects come when pain education is delivered with physiotherapy care, maintaining benefits through at least 6 months. Behavioral therapy delivered with physiotherapy care maintains clinically important effects on pain intensity through midterm follow-up with high-quality evidence. These findings reinforce the principle that psychological interventions for pain work best when integrated with, rather than delivered separately from, physical rehabilitation. The expansion of digital health technologies has enabled the delivery of CBT through telehealth platforms, online programs, and app-based tools. Remotely delivered CBT shows small but consistent benefits for pain intensity, functional disability, and quality of life compared to usual treatment. A large randomized trial enrolling 815 patients with high impact chronic pain compared telehealth and online CBT based treatments to usual care and found that both the health coach led telehealth program and the self guided online program achieved significantly higher rates of clinically meaningful pain reduction, 30% or greater improvement compared to usual care at 3, 6, and 12 months. This sustained separation between intervention and control groups throughout follow up provides compelling evidence that digital CBT approaches can produce lasting clinical benefits. The main limitation of the digital CBT evidence is that most trials compare digital treatments to no treatment rather than to face therapy. Nevertheless, digital CBT is a critically important tool for expanding access to evidence based psychological pain management, particularly for patients who face geographic, mobility, or scheduling barriers to in person care. The period around surgery represents a critical window during which psychological interventions can prevent the transition from acute to chronic pain. A 2025 meta analysis of 27 randomized controlled trials enrolling 2,990 surgical patients found that perioperative psychological interventions significantly reduced pain intensity, with an effect size of negative 0.45, and anxiety, with an effect size of negative 0.33 compared to usual care. CBT appeared most beneficial among the various approaches, and interventions delivered by psychologists were more effective than those delivered by other healthcare professionals. A critically important finding was that perioperative education alone was ineffective in reducing chronic postsurgical pain, while active psychotherapy, including CBT, relaxation therapy, or their combination, showed significant benefit. This distinction has profound implications for clinical programs. Simply providing informational handouts or preoperative educational sessions is not enough. Patients need structured, active engagement with coping skills and cognitive restructuring to gain protective benefit. Evidence also shows that interventions delivered after surgery tend to be more effective than those delivered before surgery, with significant reductions in both short-term and long-term pain and disability. This suggests that the postoperative recovery period, when pain and psychological distress are most pressing and patients are most receptive, is the optimal window for psychological intervention. The question of whether combined physical psychological interventions outperform single treatments has been addressed by several high quality trials with consistent findings. For lumbar fusion surgery, a systematic review of 18 trials involving 1,402 patients found that multimodal rehabilitation combining exercise therapy with cognitive behavioral training was more effective than exercise alone in reducing disability and pain related fear. Exercise alone was better than usual care, but adding cognitive behavioral training provided meaningful additional benefit, particularly for the psychological dimensions of pain that drive avoidance behavior and functional limitation. The most compelling evidence comes from the Toolkit for Optimal Recovery, or TOR, trials in patients with traumatic orthopedic injuries. In a secondary analysis of a randomized controlled trial involving 181 adults, only the combination of psychosocial intervention plus rehabilitation achieved clinically meaningful improvement in physical function. Neither psychosocial intervention alone nor rehabilitation alone reached this threshold. Psychosocial intervention improved pain at rest, but only the combined approach produced the functional gains that are ultimately the goal of rehabilitation. A mechanistic analysis showed that pain catastrophizing and pain-related anxiety each significantly mediated improvement in physical function. Only patients receiving the psychosocial intervention achieved clinically meaningful reductions in these psychological targets, and the effect on function was realized only when rehabilitation was also provided. This pattern suggests a complementary mechanism. Psychological intervention addresses the cognitive and emotional barriers to recovery, while physical rehabilitation provides the structured physical challenge needed to turn reduced psychological barriers into actual functional gains. A separate feasibility trial of TOR in 195 adults with acute orthopedic trauma showed sustained improvements through 3 months in physical function, pain at rest, and depressive symptoms. The TOR intervention consists of 4 weekly video-delivered sessions teaching pain coping skills, making it a scalable model for integration into multidisciplinary care. Not all patients benefit equally from psychological interventions. An efficient use of clinical resources requires identifying those most likely to respond. The evidence points to several key predictors of benefit. Patients with elevated pain catastrophizing characterized by rumination about pain, magnification of the pain threat, and feelings of helplessness represent the subgroup with the clearest indication for combined physical-psychological treatment. Pain catastrophizing is not merely associated with chronic pain, it is a modifiable mediator that, when reduced through targeted psychological treatment, translates into improvements in physical function. Similarly, pain-related anxiety and fear avoidance beliefs amplify pain and drive the avoidance of activity that perpetuates disability. Screening for these psychological risk factors using tools such as the Pain Catastrophizing Scale, or PCS, or the Fear Avoidance Beliefs Questionnaire, or FABQ, should be part of routine clinical assessment. Coexisting depression and anxiety are also significant predictors of treatment response. A meta-analysis of 24 trials found that psychological treatments for pain after musculoskeletal injury reduced depression, anxiety, and post-traumatic stress disorder symptoms immediately after treatment, though at 6 months, only depression outcomes remained significantly improved. The type and timing of injury also predict response. Larger effects are observed for patients undergoing acute rather than elective surgery, suggesting that the heightened psychological distress associated with trauma amplifies responsiveness to psychological treatment. Pain education covering neuroscience education, self-management training, and helping patients rethink their pain experience produces its strongest effects when delivered together with physiotherapy rather than as a standalone treatment. The network meta-analysis for chronic low back pain found that pain education combined with physiotherapy maintains clinically important effects on physical function and pain intensity at midterm follow-up, providing moderate quality evidence for this combined approach. This finding aligns with the broader principle that psychological strategies are most effective when embedded within the rehabilitation context where patients are actively working to restore function. Welcome to Module 6, Emerging Modalities, Neuromodulation, and Digital Therapeutics. The pain management landscape is expanding rapidly beyond traditional medications and rehabilitation to include neuromodulation technologies, digital therapeutics, and regenerative medicine. These emerging treatments offer promising additions or alternatives for patients with treatment-resistant or complex pain, and several have accumulated enough evidence to warrant integration into clinical practice under appropriate circumstances. This module reviews the current evidence for non-invasive and invasive neuromodulation, digital care programs for musculoskeletal pain, head-to-head comparisons of digital versus in-person treatments, regenerative therapies, and practical considerations for use in older adult populations. Let's start with non-invasive neuromodulation, including repetitive transcranial magnetic stimulation, or RTMS, and transcranial direct current stimulation, or TDCS. A 2025 Lancet Neurology systematic review confirmed that high-frequency RTMS targeting the motor cortex of the brain is effective for neuropathic pain, with a meaningful effect size for neuropathic pain conditions. However, when analyzed across all chronic pain conditions, the effect translates to approximately a 7% reduction in pain intensity, below the threshold generally considered clinically important, which is 15%. This highlights that RTMS works best for neuropathic rather than nociceptive or tissue-based pain conditions. The 2025 Lancet Neurology review positioned high-frequency motor cortex RTMS as a third-line therapy for neuropathic pain, reflecting the limited certainty of evidence, limited availability of equipment and trained staff, high treatment costs, and the need for multiple clinic visits. Anadol TDCS shows moderate quality evidence for pain relief in chronic conditions, with a more favorable cost profile than RTMS, though the evidence base is smaller. For older adults, non-invasive neuromodulation offers the advantage of avoiding body-wide drug exposure in a population vulnerable to medication-related problems. The American Geriatric Society has included neuromodulation among recommended non-drug options for older adults. However, practical barriers currently limit widespread clinical adoption. Non-invasive neuromodulation is most appropriate for patients with chronic neuropathic pain who have not responded to first and second-line medications and who want to avoid or reduce their medication burden. For patients with treatment-resistant chronic pain who have failed multiple conservative treatments, invasive neuromodulation offers an important escalation option. Spinal cord stimulation, or SCS, has level 1 evidence supporting its use for persistent post-surgical neuropathic pain, complex regional pain syndrome, chronic limb ischemia that cannot be surgically treated, treatment-resistant angina, and painful diabetic neuropathy. SCS provides meaningful pain improvement and decreased medication use with acceptably low complication rates and has been shown to be cost-effective for patients in whom medications have failed. Improved device technology, including high-frequency and burst stimulation patterns, has enhanced outcomes over the past decade. Peripheral nerve stimulation, or PNS, shows low to moderate quality evidence for pain reduction and quality of life improvement in neuropathic pain affecting one or two nerves, with benefits extending beyond 1 year. Dorsal root ganglion stimulation offers greater anatomic precision and may benefit focal neuropathic pain that is not adequately covered by conventional SCS. All invasive neuromodulation requires careful patient selection within an interdisciplinary care model and following appropriate psychological evaluation. Patients with widespread pain and active psychological disorders are generally poor candidates, and in older adults, surgical risks must be weighed against the potential long-term benefits. Digital therapeutics encompassing app-based education, sensor-guided exercise therapy, CBT, and remote health coaching have generated substantial evidence for chronic musculoskeletal pain management. A systematic review and meta-analysis found that digital health interventions produce small but consistent improvements in pain, disability, quality of life, and self-management compared to usual care. A large study of over 10,000 participants with chronic knee and low back pain showed a 68% average improvement in pain using a 12-week digital care program, with 73% completion rates and a positive relationship between engagement measured by exercise sessions and coaching interactions and pain reduction. Cost-effectiveness analyses consistently favor digital interventions, with a meta-analysis showing pooled cost savings of $417.52 favoring digital over control groups. At 12 months, participants in digital musculoskeletal programs had lower use of invasive services, imaging, and conservative healthcare services compared to non-participants, suggesting that digital programs may reduce downstream healthcare costs in addition to improving clinical outcomes. The critical clinical question is whether digital treatments are equivalent to traditional in-person care. The most rigorous trials consistently demonstrate non-inferiority or equivalence rather than superiority of digital approaches, with benefits sustained at 6 to 12 months. The PEAK trial, the largest and most rigorous non-inferiority randomized controlled trial with 394 participants and an average age of 62, compared video conference telerehabilitation to in-person physiotherapy for chronic knee pain consistent with osteoarthritis. At the 3-month primary endpoint, telerehabilitation was non-inferior to in-person care for both pain on the NRS and physical function on the WOMAC, with improvements exceeding clinically important thresholds in both groups. At 9 months, telerehabilitation remained non-inferior and was superior for physical activity, therapeutic relationship, convenience, satisfaction, attendance, and strength exercise adherence. Cost-effectiveness analysis showed telerehabilitation offered net social benefits due to cost savings including private time and travel. A Swedish registry study of 6,946 patients with an average age of 67 comparing face-to-face versus digital delivery of a structured osteoarthritis program found that both interventions produced clinically important pain reductions at 3 months. A separate randomized trial of 140 patients comparing a digital care program to conventional in-person physiotherapy for chronic low back pain found no significant differences in disability, pain, anxiety, depression, or productivity impairment. The digital group had significantly lower dropout rates, 15.7% versus 34.3%, suggesting digital delivery may improve treatment completion. A clinically important finding because the most effective treatment is one patient's actually finish. For older adults, digital pain management interventions have been shown to be feasible and acceptable when appropriately designed, but the evidence base remains limited to feasibility studies rather than large efficacy trials. Research indicates that older adults require tailored information specific to their needs, structured goal setting with reminders, healthcare professional support alongside the digital program, and a focus on changing attitudes and perceptions about pain. Health literacy adaptations, caregiver involvement, device use training, and maintained clinician contact are critical design features for digital programs serving older adults. High engagement correlates with better outcomes across all ages. Regenerative medicine approaches, including platelet-rich plasma, or PRP, injections, and autologous stem cell therapies, are under active investigation for chronic musculoskeletal and degenerative pain conditions. These therapies aim to repair damaged tissues and modify pain pathways at the cellular level, potentially addressing the root cause of pain rather than merely managing symptoms. Advanced biomaterials, including injectable scaffolds and nanoparticle-based drug delivery systems, offer the possibility of targeted, sustained pain relief at the site of disease. While the theoretical promise is substantial, these therapies are not yet standard of care. The evidence consists primarily of early-phase trials with small sample sizes and limited follow-up, and regulatory frameworks are still evolving. In older adults, altered healing capacity and potential for complications add additional considerations. Clinicians should be prepared to discuss regenerative therapies with patients who ask about them, providing a balanced assessment of the current evidence and clearly distinguishing between established treatments and those still under investigation. Let's close Module 6 with a clinical decision framework comparing neuromodulation to pharmacologic agents. No head-to-head randomized controlled trials directly compare neuromodulation to topical NSAIDs in geriatric populations. However, indirect comparisons using number needed to treat values and effect sizes from separate meta-analyses inform clinical reasoning. Topical NSAIDs demonstrate superior efficacy for acute musculoskeletal pain with an NNT of 1.8 and established efficacy for osteoarthritis with NNTs of 5.0 to 9.8, along with an excellent safety profile. TENS provides moderate pain relief during stimulation but inconsistent evidence for sustained benefit, while RTMS shows modest effects primarily for neuropathic pain as a third-line option. For older adults with acute musculoskeletal injuries, topical NSAIDs remain first line. For knee osteoarthritis, topical NSAIDs remain the preferred medication, with TENS combined with exercise as a reasonable addition. For neuropathic pain, topical capsaicin and lidocaine are first-line topical options, with RTMS reserved for treatment-resistant cases. For frail older adults with multiple medications who cannot tolerate systemic drugs, TENS offers a non-drug alternative with no drug interactions, no body-wide effects, and minimal side effects, a significant clinical advantage despite its relatively modest pain-relieving effect. Welcome to Module 7, Multidisciplinary Integration, Outcome Measures, and Implementation. The preceding modules have established the scientific foundations and clinical evidence for each component of multidisciplinary pain management: pathophysiology, assessment, medications, physical rehabilitation, psychological treatment, and emerging technologies. This final content module tackles the critical challenge of putting all these components together into a functioning clinical workflow. The gap between knowing what works and making it work in practice is substantial, and it is at the level of implementation that many pain management programs fall short. This module examines the evidence for specific team structures and care models, the selection and use of validated outcome measures, opioid deprescribing strategies, cultural and language considerations, and the barriers and facilitators that determine whether evidence-based multidisciplinary care is successfully adopted. Let's begin with the evidence for team structures that work. The evidence consistently shows that structured, interdisciplinary team approaches produce better outcomes than usual care for chronic pain management. A systematic review of 20 randomized controlled trials examining teaming and interdisciplinary chronic pain management in primary care identified several structural features that distinguish effective programs from ineffective ones. The most critical feature was the presence of a care manager, most commonly a nurse, who served as the primary point of contact for patients, coordinated communication among team members, tracked patient progress, and ensured adherence to treatment protocols. Programs with a care manager showed significantly greater improvements in pain and function. Nurse practitioner-led pain management teams have shown particularly strong outcomes in long-term care settings. A controlled study of 345 residents with an average age over 75 in long-term care found that a structured nurse-led pain team approach produced significant improvements in both pain intensity and functional status compared to usual care. A comprehensive nurse-led chronic pain management program in primary care showed sustained improvements across multiple domains at 9 months, with large effect sizes for mental health and moderate effect sizes for anxiety, pain, and depression. These findings validate the nurse as a central figure in pain management teams. The VOICE randomized clinical trial, one of the largest trials of interdisciplinary pain care, enrolled patients on long-term opioid therapy and compared collaborative telehealth-based care management to usual care. The collaborative model integrated a nurse care manager, pharmacist, and pain physician and achieved significant reductions in both pain intensity and opioid use, demonstrating that team-based care can simultaneously improve pain outcomes and support opioid reduction. This trial provides level 1 evidence that the multidisciplinary model is a practical, implementable approach that produces measurable clinical results. Occupational therapists play a distinctive and increasingly well-documented role in pain management, particularly for hand and upper extremity conditions, osteoarthritis, and restoring functional independence in older adults. A multi-center randomized trial of 374 patients with an average age of 63.6 with hand osteoarthritis showed that occupational therapy-led care was non-inferior to rheumatologist-led care, with virtually identical response rates, 28.6% versus 28.4%, and cost effectiveness. This finding has important implications. Occupational therapists can serve as primary providers for hand osteoarthritis management, expanding access to evidence based care and freeing specialist resources for more complex cases. For carpometacarpal, or thumb base, osteoarthritis specifically, a randomized trial of 180 patients showed that multimodal occupational therapy combining joint protection education, therapeutic exercises, orthosis provision, and assistive device training was superior to usual care across all primary outcomes: pain at rest, grip strength, and disability. Cost utility analysis revealed that patients in the occupational therapy group gained more quality adjusted life years at lower total cost, with a 94.5% probability of being cost effective. The specific OT protocols include joint protection education covering disease processes and ergonomic modifications, hand exercise programs performed 2 to 3 times weekly targeting range of motion and neuromuscular control, and rigid thermoplastic splints worn a minimum of 4 hours daily during functional activities. For frail older adults, home and community-based occupational therapy interventions improve activities of daily living, social participation, and mobility, providing clinically meaningful functional benefits for a population particularly vulnerable to pain-related disability. Following hip fracture, multidisciplinary rehabilitation that includes occupational therapy probably results in fewer poor outcomes, and interdisciplinary geriatric team rehabilitation has been shown to increase both function and mobility. Standardized outcome measurement is essential for evaluating treatment effectiveness, communicating progress across the team, and satisfying quality improvement requirements. An international consensus process established core outcome domains for pain research and clinical practice, organized by pain phase: acute pain, the transition from acute to chronic pain, recurrent pain, and chronic pain. Across all phases, the recommended core domains include pain intensity, physical function, emotional function, and patient global assessment. For pain intensity, the numeric rating scale with 1-week recall has achieved near universal consensus 96% agreement as the preferred measure, with minimally important differences of 1 to 2 points on a 0 to 10 scale. For back-specific function, the Oswestry Disability Index and the Roland Morris Disability Questionnaire are both endorsed as top-tier instruments. For generic health status, the short form 36 or short form 12 capture the broader impact of pain across physical, mental, and social domains. Performance-based outcome measures complement patient-reported tools by providing objective data on physical capacity. Measures with moderate to strong evidence for reliability and validity in older adults with pain include the 5-repetition sit-to-stand test, which correlates with lower extremity strength and fall risk; the timed up-and-go test, which assesses functional mobility and dynamic balance; and the 5-minute or 50-foot walk tests, which measure walking speed and endurance. For hip and knee osteoarthritis, the WOMAC, KOOS, HOTS, and 30-second chair stand test all demonstrate strong evidence for detecting clinically meaningful functional changes. The Activity Pacing Questionnaire 12, or APQ-12 framework, provides a structured approach to assessing and teaching activity pacing across 4 domains: adjustment, planning, consistency, and progression. Systematic review evidence shows that activity pacing effectively reduces joint stiffness, fatigue interference, and physical activity variability, though it does not directly reduce pain severity. The clinical value of pacing lies in its impact on functional engagement. Patients who show high pacing with low avoidance demonstrate the best functioning outcomes. A critical function of multidisciplinary pain programs is supporting the safe reduction or discontinuation of opioid therapy for patients with chronic non-cancer pain. A systematic review found that team-based approaches integrating pharmacist-led medication review, nurse care management, and psychological support produce the most consistent reductions in opioid use. The evidence supports a patient-centered, voluntary approach that avoids abrupt discontinuation and instead uses gradual tapering with concurrent optimization of non-opioid medications and non-drug therapies. Key principles of effective opioid deprescribing include building a therapeutic relationship based on trust and shared decision-making, setting realistic expectations that function improvement rather than complete pain elimination is the goal, implementing gradual dose reductions of 5 to 10% per month while monitoring for withdrawal symptoms and pain flares, optimizing non-opioid medications before and during the taper, ensuring access to physical therapy, psychological support, and self-management education throughout the process, and monitoring closely for psychological distress. The VOICE trial demonstrated that this integrated approach is effective and achievable within primary care settings. The multidisciplinary pain management workflow should be organized according to a stepped care model that matches treatment intensity to patient complexity and treatment response. At the foundation, Step 1, all patients receive validated pain assessment, patient education, activity counseling, and topical medications as indicated. Patients with an insufficient response move to Step 2, which adds structured exercise therapy, oral non-opioid medications, and basic psychological strategies delivered by the primary treating clinician. Step 3 introduces formal interdisciplinary collaboration, including referral for specialized physical therapy, occupational therapy, psychology, or pain medicine consultation. Step 4, reserved for treatment-resistant patients, includes advanced interventions such as neuromodulation, intensive multidisciplinary rehabilitation programs, and invasive procedures. This model ensures that most patients are managed effectively with lower intensity, lower cost treatments, while those with more complex pain presentations receive appropriately intensive care. Clear criteria for escalation defined by validated outcome measures and functional benchmarks prevent both premature escalation and inadequate treatment. Cultural background profoundly influences the pain experience and how it is expressed. Let's discuss the cultural, linguistic, and health equity considerations that are essential to effective pain management. Research has documented significant variation in pain perception, pain expression, health-seeking behavior, treatment preferences, and communication styles across cultural groups. A scoping review of cultural tailoring in pain management identified 3 fundamental areas requiring adaptation, communication, including language concordant care, culturally validated assessment tools, and awareness of culture-specific pain descriptions, treatment preferences, including incorporating traditional healing practices, spiritual beliefs, and family decision-making structures into treatment planning, and systemic access, including addressing disparities in referral patterns, insurance coverage, geographic accessibility, and provider diversity. Clinicians should be trained to recognize that stoicism about pain may reflect cultural norms rather than absence of pain, that some cultural groups prefer family-centered rather than individual decision-making about treatment, that religious and spiritual beliefs may influence attitudes toward medications and invasive procedures, and that health literacy varies widely and should be assessed before providing written materials. Validated assessment tools should be administered in the patient's preferred language using professionally translated and culturally adapted versions, and interpreter services should be readily available. Culturally responsive pain management is not merely a matter of sensitivity, it is a matter of clinical accuracy. Pain assessment that fails to account for cultural expression patterns will systematically underestimate pain in some populations and overestimate it in others, leading to disparities in treatment quality. Let's close Module 7 with a look at the barriers, facilitators, and implementation considerations for multidisciplinary pain management. Implementation of multidisciplinary pain management faces well-documented barriers including fragmented care systems, inadequate reimbursement for team-based care, limited specialist availability, competing clinical priorities, lack of standardized communication protocols among team members, and insufficient training in biopsychosocial approaches during professional education. Facilitators of successful implementation include administrative leadership support, dedicated funding for team coordination, standardized clinical pathways embedded in electronic health records, regular interdisciplinary team meetings, shared outcome dashboards that track patient progress across providers, and ongoing professional education. The economic case for multidisciplinary pain management is compelling. Cost-effectiveness analyses consistently show that multimodal programs reduce downstream healthcare use, including emergency department visits, imaging studies, specialist referrals, and surgical interventions, while improving patient outcomes and functional status. Investing in multidisciplinary pain infrastructure represents not only better clinical care, but also more efficient resource allocation. Welcome to Module 8, Integrated Clinical Case Studies. This module presents 3 detailed clinical case studies that require you to apply the core concepts from Modules 1 through 7. Each case follows a patient through a complex pain management trajectory and is constructed so that clinical decision-making at each stage draws directly upon the pathophysiology, assessment strategies, pharmacologic principles, rehabilitative interventions, psychological considerations, emerging technologies, and team-based workflow concepts covered throughout this course. Our first case is Margaret T. Murrah, a 74-year-old retired school teacher who presents for evaluation on postoperative day 2 following an elective right total knee arthroplasty performed for advanced osteoarthritis with bone-on-bone changes. Her medical history includes bilateral knee osteoarthritis with progressive functional decline over 4 years, chronic low back pain of 8 years managed with acetaminophen and occasional oral ibuprofen, major depressive disorder treated with sertraline 100 mg daily, well-controlled hypertension on lisinopril 20 mg, and amlodipine 5 mg daily, stage 2 chronic kidney disease with an estimated glomerular filtration rate of 62 milliliters per minute, mild cognitive impairment diagnosed 14 months ago with a Montreal Cognitive Assessment score of 22 out of 30 showing Margaret lives alone in a single-story home. Her adult daughter lives 45 minutes away and is actively involved in her care. Margaret identifies as African American and has expressed concerns to the nursing staff that her pain may not be taken as seriously as that of other patients, a concern rooted in past healthcare experiences that she has shared with her daughter, but not directly with the medical team. Her preoperative pain was 7 out of 10 with activity and 3 out of 10 at rest in the affected knee, with chronic low back pain rated at 4 out of 10. Preoperative screening showed an elevated pain catastrophizing scale score of 32 out of 52, particularly high on the rumination and helplessness subscales, and a patient health questionnaire 9 score of 11, indicating moderate depressive symptoms despite ongoing sertraline therapy. On postoperative day 2, Margaret rates her right knee pain at 8 out of 10 at rest and 10 out of 10 with physical therapy attempts. She is tearful and states, "This pain is unbearable. I don't think I'll ever walk normally again." She has been receiving intravenous morphine via patient-controlled analgesia since surgery, averaging 28 milligrams of morphine equivalent per 24 hours. From a pathophysiology perspective, Margaret's acute postoperative pain reflects activation of peripheral nociceptors by inflammatory chemicals at the surgical site, transmitted via pain nerve fibers to the spinal cord. Her pain intensity is higher than expected, raising concern for several risk factors for chronic postsurgical pain. Nerve handling during total knee arthroplasty may have initiated peripheral sensitization. Sustained high-intensity pain input can trigger central sensitization through NMDA receptor activation in the spinal cord. Her age-related decline in natural pain suppression systems reduces her ability to dampen pain signals, and her elevated pain, catastrophizing, and depressive symptoms create top-down amplification of pain perception. These converging risk factors place Margaret at elevated risk for the transition from acute to chronic pain. For pain assessment, with a Montreal Cognitive Assessment score of 22, Margaret retains the ability for reliable self-report, but the team should allow extra response time, simplify questions as needed, and remember that her retrospective estimates of usual and worse pain may be more reliable than other recall types. The NRS remains appropriate for tracking pain intensity. However, pain intensity alone is insufficient. The brief pain inventory interference subscale should be added to capture how pain is affecting her function, mood, and sleep. Given her pre-existing chronic low back pain, the ODI or RMDQ should be applied at baseline and regular intervals. The physical therapist should document baseline performance on the timed up-and-go test and 5-repetition sit-to-stand test. Margaret's concern about racial bias in pain management represents an important cultural dimension. Proactive, culturally sensitive inquiry using open-ended questions and validating her pain experience is necessary to build trust. For pharmacologic management, the current reliance on intravenous morphine is suboptimal. Opioids are not superior to non-opioid therapies for pain-related function in chronic musculoskeletal pain, and older adults face elevated risk for opioid-related falls, cognitive impairment, respiratory depression, and constipation. Margaret's mild cognitive impairment makes her particularly vulnerable to opioid-induced delirium, and her chronic kidney disease impairs clearance of morphine metabolites. The Pain Service recommends transitioning to a multimodal non-opioid regimen, topical diclofenac gel to the periincisional area with an NNT of 1.8 and side effect rate indistinguishable from placebo, scheduled oral acetaminophen at 1,000 milligrams every 8 hours with a maximum of 2,000 milligrams daily given her age for background analgesia with the lowest fall risk in consideration of a short course of low-dose oral ibuprofen only if needed, with renal monitoring given her kidney disease. Duloxetine is deferred due to 2025 data showing increased fall-related visits compared to gabapentin, adding a centrally acting medication during the immediate postoperative period when fall risk is already elevated is not warranted. The morphine patient-controlled analgesia is tapered over 48 hours with a goal of discontinuation by postoperative day 4. By postoperative day 3, Margaret's pain has improved to 5 out of 10 at rest and 7 out of 10 with activity. She participates in physical therapy but is guarded and anxious, expressing fears that movement will damage the new knee. She avoids full weight bearing despite surgical clearance and declines stair negotiation. Her functional progress is below expected trajectory, despite adequate pain control at rest. Margaret exemplifies the high-benefit subgroup identified in Module 5. Her elevated pain catastrophizing score of 32 and the TOR trial evidence that only the combination of psychosocial intervention plus rehabilitation achieves clinically meaningful functional improvement have direct implications. Physical therapy without psychological support will likely produce suboptimal functional gains. The 2025 meta-analysis confirms that active psychotherapy reduces persistent postsurgical pain and disability, while education alone is ineffective. Margaret is in the optimal postoperative window for psychological intervention, and psychologist delivered interventions are more effective than those from other professionals. The psychologist initiates a brief CBT intervention modeled on Torger 4 sessions, 2 inpatient, 2 via telehealth, focusing on cognitive restructuring of catastrophic pain beliefs, relaxation techniques, graded behavioral activation, and pain coping skills. Concurrently, the physical therapist adjusts rehabilitation to incorporate graded exposure, progressing weight bearing and functional tasks in small, achievable steps that build confidence. Margaret is discharged on postoperative day 6 with pain of 4 out of 10 at rest and 6 out of 10 with activity. She is ambulating with a rolling walker on level surfaces and has negotiated 4 stairs with a railing. Discharge medications include topical diclofenac gel twice daily, acetaminophen 1,000 milligrams 3 times daily, sertraline, lisinopril, and amlodipine. No opioids are prescribed at discharge. The inpatient to outpatient transition is a high-risk period for care fragmentation. The plan assigns a nurse care manager for structured telephone follow-up using the NRS and BPI, medication adherence monitoring, and coordination among the outpatient physical therapist, psychologist, and primary care physician. Given Margaret's geographic and mobility challenges, digital therapeutics supplement in-person rehabilitation. The PEAK trial showed telerehabilitation non-inferior to in-person physiotherapy for chronic knee pain, and large cohort studies support digital exercise programs with 73% completion rates. Margaret's cognitive impairment requires her daughter's involvement in setup, simplified navigation, and weekly health coach contact. At 6 weeks, Margaret reports right knee pain of 3 out of 10 at rest and 5 out of 10 with activity. Her chronic low back pain has worsened to 5 out of 10, attributed to altered gait during recovery. Her pain catastrophizing scale has decreased from 32 to 18 and PHQ-9 from 11 to 7. She is ambulating with a cane and has returned to light housekeeping. Timed up and go has improved from 24 to 16 seconds. She also reports new difficulty with grip strength, dropping objects, and 30-minute morning finger stiffness. Examination reveals Heberden's nodes and first carpo-metacarpal joint squaring with tenderness. For worsening low back pain, duloxetine can now be reconsidered. With Margaret ambulatory and improving, and given its dual benefit for pain and her residual depression with a PHQ-9 of 7, duloxetine is initiated at 30 milligrams daily with planned titration to 60 milligrams with fall risk monitoring. Her sertraline could be cross-tapered to duloxetine under psychiatric guidance to reduce polypharmacy. For hand osteoarthritis, the evidence supports occupational therapy-led multimodal management, joint protection education, a home hand exercise program 2 to 3 times weekly, a rigid thermoplastic splint for the first carpo-metacarpal joint worn during activities, and assistive devices. Topical diclofenac gel is extended to the hand joints. At 3 months, Margaret's right knee pain is 2 out of 10 at rest and 3 out of 10 with activity. Chronic low back pain has improved to 3 out of 10 on duloxetine 60 milligrams daily with sertraline discontinued. Hand pain is 2 out of 10 at rest and 3 out of 10 with gripping. PHQ-9 is 5, and pain catastrophizing scale is 14. Timed up and go is 12 seconds. She has transitioned to a community exercise class and maintains her OAT-prescribed hand exercise program. Applying outcome benchmarks, right knee pain decreased by 75%, exceeding the 30% clinically meaningful threshold. Low back pain improved by 40%, also exceeding threshold. Timed up and go improved from 24 to 12 seconds, which is clinically meaningful. Pain catastrophizing scale decreased from 32 to 14, below the threshold associated with poor outcomes, confirming the psychological intervention achieved its objective. And PHQ-9 improved from 11 to 5, moving from moderate to mild depression. Margaret's success reflects the integration of every module: early identification of chronification risk, adaptive assessment, multimodal pharmacotherapy with geriatric safety, graded rehabilitation, timely psychological intervention, digital therapeutics, and nurse-coordinated team workflow. Our second case is Robert K., a 69-year-old retired firefighter who presents to a primary care-based multidisciplinary pain clinic with a 12-year history of chronic low back pain and bilateral lower extremity radiculopathy secondary to multilevel lumbar degenerative disc disease and spinal stenosis. He was evaluated by a spine surgeon 2 years ago and was not considered a surgical candidate due to the diffuse nature of his disease. His medical history also includes type 2 diabetes mellitus with peripheral neuropathy affecting the feet and a hemoglobin A1C of 7.4%, hyperlipidemia managed with atorvastatin 40 mg daily, benign prostatic hyperplasia managed with tamsulosin 0.4 mg daily, and a remote history of alcohol use disorder with 10 years of sobriety. He has no cognitive impairment with a Montreal Cognitive Assessment of 28 out of 30. His BMI is 28.7. Robert lives with his wife in a two-story home. He has become increasingly sedentary over the past 3 years, spending most of his day in a recliner. He reports difficulty sleeping due to leg pain, averaging 4 to 5 hours of fragmented sleep per night. He has been taking oxycodone 10 mg 4 times daily for the past 6 years, gabapentin 300 mg 3 times daily, and over-the-counter ibuprofen 400 mg several times a day on top of his prescriptions. He was referred by his new primary care provider with a request for a comprehensive pain reassessment and guidance on opioid deprescribing. His current pain assessment shows low back pain rated at 6 out of 10 at rest and 8 out of 10 with activity on the NRS. Bilateral foot burning and numbness rated at 5 out of 10 on the NRS. Oswestry Disability Index score of 48, indicating severe disability. PHQ-9 score of 9, indicating mild depression. Pain Catastrophizing Scale score of 22, which is moderate. Fear Avoidance Beliefs Questionnaire Physical Activity Subscale score of 19, which is elevated. 5 repetitions sit-to-stand test, 22 seconds, below normal. Timed up and go, 18 seconds, indicating elevated fall risk. Robert is cognitively intact, so standard self-report tools are appropriate. The NRS is used for pain intensity tracking. The ODI score of 48 places him in the severe disability category, establishing a functional baseline. The BPI interference subscale is added to capture the specific functional domains affected. In Robert's case, sleep disruption is a primary concern. His elevated FABQ score of 19 and moderate PCS score of 22 identify him as a patient who would benefit from combined physical-psychological intervention. Performance-based measures sit-to-stand at 22 seconds and tug at 18 seconds provide objective evidence of functional limitation and elevated fall risk. From a pathophysiology perspective, Robert's pain presentation involves both nociceptive and neuropathic mechanisms. His chronic low back pain has a nociceptive component from degenerative disc disease and spinal stenosis, but his bilateral radiculopathy and diabetic peripheral neuropathy involve neuropathic mechanisms including nerve compression, peripheral sensitization, and likely central sensitization given the 12-year duration. His diabetic neuropathy involves small fiber damage and neuroinflammation that compounds the spinal pathology. After 12 years of chronic pain, maladaptive neuroplasticity and cortical reorganization are likely established, meaning that his pain experience is driven partly by changes in his brain, rather than solely by ongoing tissue damage. His prolonged inactivity has contributed to deconditioning that further amplifies pain through muscle weakness, joint stiffness, and reduced cardiovascular fitness. Robert's current medication regimen has several concerns. His opioid use of oxycodone 40 mg daily places him at significant risk for falls, cognitive effects, respiratory depression, and constipation. The landmark SPACE trial demonstrated that opioids are not superior to non-opioid therapy for chronic back pain function. His unsupervised ibuprofen use is concerning given his age and the risks of gastrointestinal bleeding, renal impairment, and cardiovascular events with chronic NSAID use. His gabapentin dose of 900 mg daily is subtherapeutic for neuropathic pain and contributes to his fall risk. His tamsulosin, an alpha blocker, further increases fall risk through orthostatic hypotension when combined with centrally acting medications. The medication optimization plan addresses each issue systematically. First, the ibuprofen is discontinued and replaced with topical diclofenac gel to the low back, providing localized NSAID benefit without the systemic risks. Second, for his neuropathic pain, both radiculopathy and diabetic neuropathy, duloxetine 30 mg daily is initiated with planned titration to 60 mg, which also addresses his mild depression. Third, gabapentin is optimized. Rather than continued at an ineffective dose, the plan is to either titrate to an effective dose of 1,200 to 1,800 mg daily in divided doses for his neuropathic indications with careful fall risk monitoring, or cross-taper to duloxetine monotherapy if duloxetine provides adequate relief. Gabapentin should not be used for his low back pain, where it has no benefit. Fourth, topical lidocaine 5% patches are prescribed for his bilateral foot neuropathy, providing localized relief with no systemic absorption or drug interactions. Fifth, scheduled acetaminophen 1,000 mg twice daily provides background analgesia with the lowest fall risk. The opioid taper follows evidence-based principles. A therapeutic alliance is established through shared decision making, with clear communication that the goal is improved function rather than complete pain elimination. Robert is informed that the SPACE trials showed non-opioid medications produced equal or better functional outcomes than opioids for his exact conditions. The taper proceeds at 5% per month, reducing by 2 to 4 milligrams of oxycodone per month, with monitoring for withdrawal symptoms and pain flares. Non-opioid medications are fully established before each dose reduction step. The nurse care manager conducts biweekly telephone follow-up during the taper using the NRS, BPI, and screening for psychological distress. Robert is reassured that the taper will be paused or slowed if needed. This is a voluntary, patient-centered process. Robert's deconditioning is a primary treatment target. Exercise therapy is the single most broadly recommended non-pharmacologic intervention for chronic pain, with strong evidence for functional improvement. His program includes graded low-impact aerobic exercise starting with 10-minute walks and progressing to 30 minutes, targeted lumbar stabilization exercises for back pain associated with deconditioning, balance training given his elevated fall risk with a tug of 18 seconds, and flexibility work for his lumbar spine. The physical therapist incorporates TENS as an adjunct during sessions using conventional high-frequency TENS at 80 Hz at strong but comfortable intensity over the low back for 30-minute sessions, with additional electrode placement along the L4 through S1 distribution for his radiculopathy. TENS is particularly valuable for Robert because it provides drug-free pain relief during exercise, helping him overcome the initial barrier of movement-related pain that his fear avoidance beliefs amplify. Robert's elevated FABQ score of 19 and moderate PCS score of 22 identify him as a patient who will benefit from combined physical-psychological intervention. His 6-year pattern of recliner-based sedentary behavior represents classic fear avoidance. He avoids movement because he believes it will worsen his pain, which leads to deconditioning that actually increases his pain, creating a vicious cycle. The pain psychologist initiates group-based CBT over 6 weekly sessions focusing on cognitive restructuring of fear avoidance beliefs, graded behavioral activation with progressive daily activity goals, sleep hygiene education for his pain-related insomnia, and relaxation training. The network meta-analysis for chronic low back pain shows that CBT combined with physiotherapy produces clinically important improvements in physical function. Pain education is integrated into the physiotherapy sessions, helping Robert understand that his 12-year-old pain does not mean ongoing tissue damage, a critical reconceptualization that reduces the perceived threat of movement. At 3 months, Robert reports low back pain of 4 out of 10 at rest and 6 out of 10 with activity. Foot pain is 3 out of 10 on duloxetine 60 mg daily and topical lidocaine. He has reduced oxycodone from 40 mg to 30 mg daily without significant withdrawal or pain flares. His ODI has improved from 48 to 34, a 14-point improvement exceeding the 10-point minimally important difference. His PHQ-9 has improved from 9 to 5. He is walking 20 minutes daily, sleeping 6 hours per night, and reports using relaxation techniques before bed. His sit-to-stand time has improved from 22 to 16 seconds and tug from 18 to 14 seconds. At 6 months, Robert has tapered to oxycodone 15 mg daily, with a plan for complete discontinuation over the next 4 to 6 months. His low back pain is 3 out of 10 at rest and 5 out of 10 with activity. He has joined a community walking group 3 times weekly and is cooking meals again, activities he had given up 3 years ago. His wife reports he seems like a different person. The team discusses transitioning his care to a maintenance phase with quarterly follow-up, continued exercise, and the digital exercise program for ongoing home-based rehabilitation. His FABQ has decreased from 19 to 8 and PCS from 22 to 10, confirming that the psychological targets driving his avoidance behavior have been effectively addressed. Robert's case illustrates several principles. The importance of comprehensive reassessment rather than accepting a long-standing medication regimen at face value, the clinical impact of systematic opioid deprescribing supported by concurrent non-opioid optimization, the power of combined physical-logical intervention to break the fear avoidance cycle, and the role of the multidisciplinary team nurse care manager, physical therapist, psychologist, pharmacist, and primary care physician in producing outcomes that no single provider could achieve alone. Our third case is Elena V., an 82-year-old retired seamstress who resides in a long-term care facility. She sustained a left intertrochanteric hip fracture after a witnessed fall from her wheelchair during a transfer. She underwent open reduction and internal fixation the same day and is returned to the facility on postoperative day 3 for continued recovery. Her medical history includes advanced Alzheimer's dementia at global deterioration scale stage 6 diagnosed 5 years ago, osteoporosis with a prior T1-2 vertebral compression fracture 2 years ago, type 2 diabetes mellitus managed with metformin 500 mg twice daily, and glipizide 5 mg daily, hypertension managed with hydrochlorothiazide 25 mg daily, and metoprolol succinate 50 mg daily, osteoarthritis of both knees and the lumbar spine, gastroesophageal reflux disease managed with omeprazole 20 mg daily, and a history of recurrent urinary tract infections. Her BMI is 22.1. Elena's primary language is Spanish, and she spoke limited English even before the onset of dementia. She is now essentially nonverbal, occasionally producing single Spanish words or short phrases that are difficult for staff to interpret. Her daughter, Maria, serves as her healthcare proxy and visits 3 to 4 times per week. Maria reports that before the fall, Elena had been showing increasing agitation and resistance to care over the preceding 2 weeks, behaviors that the facility staff attributed to dementia progression. Elena's current medications also include a standing order for acetaminophen 500 mg twice daily that was prescribed 6 months ago and has not been reassessed, and an as-needed order for tramadol 25 mg every 6 hours that was added by the hospital surgical team at discharge. Elena cannot participate in standard cognitive testing. Her most recent documented assessment from 8 months ago noted that she was unable to follow two-step commands, did not recognize family members by name, though she appeared to respond to Maria's voice and touch, and required full assistance for all activities of daily living, including eating, dressing, bathing, toileting, and transfers. She had been using a wheelchair with assistance for mobility prior to the fracture. Upon return to the facility, the nursing staff reports that Elena is moaning intermittently, grimacing when her left leg is moved during repositioning, pulling away from caregivers during perineal care, and refusing to open her mouth for oral medications. The certified nursing assistant notes that Elena has not eaten more than a few bites at meals since returning, and is sleeping in short, fragmented intervals. The tramadol has been administered once in 24 hours, because the nurse on the prior shift documented patient resting comfortably, no signs of distress. Elena's advanced dementia and nonverbal status makes self-report impossible, requiring the team to rely on observational pain assessment tools. The hierarchical approach is followed. Attempt self-report using simplified methods, which is not feasible for Elena. Systematically identify potential causes of pain, with the postoperative hip fracture as an obvious source, plus her pre-existing bilateral knee and lumbar osteoarthritis. Observe and document pain-related behaviors, and seek input from caregivers who know the patient's patterns. The discrepancy between the prior shift's documentation of resting comfortably and the current shift's observations of moaning, grimacing, guarding care resistance, and appetite loss highlights the critical value of standardized observational tools. The PACS detected pain in 27.1% of cases where clinical judgment alone found no pain behaviors. The nurse applies the pain ad scale. Breathing is scored 1 for occasional labored breathing. Negative vocalization is scored 2 for repeated moaning. Facial expression is scored 2 for grimacing. Body language is scored 2 for rigid guarding and pulling away. And consolability is scored 1 for being distracted by voice but unable to be consoled by touch. Total pain ad score, 8 out of 10, indicating severe pain. This score provides an objective, documentable baseline against which treatment response can be measured. The pain ad has demonstrated sensitivity to analgesic interventions, meaning scores should reliably decrease following effective treatment. Maria, Elena's daughter, is contacted by phone, using a professional Spanish language interpreter, not a family member, to ensure accuracy and reduce burden on Maria. The nurse care manager conducts a structured interview. Maria reports that Elena's agitation and care resistance over the 2 weeks before the fall were unusual. Elena had previously been calm and cooperative during transfers and personal care. Maria suspects Elena was in pain before the fracture occurred and wonders whether unrecognized pain contributed to the restlessness that led to the fall. This information is clinically significant. Older adults with age-related decline in peripheral nerve function may have delayed pain awareness and difficulty localizing pain. And Maria's observation raises the possibility that worsening osteoarthritis or the prior vertebral compression fracture was generating unrecognized pain that manifested as behavioral changes attributed to dementia progression. Family and caregiver input should be systematically solicited and documented, particularly for patients with cognitive impairment. The medication reconciliation for Elena reveals several problems. Her standing acetaminophen dose of 500 mg twice daily, totaling 1,000 mg per day, is subtherapeutic for postoperative pain. Scheduled acetaminophen provides the best background analgesia with the lowest fall risk of any systemic analgesic. Given her age and low body weight, the dose is increased to 500 mg 3 times daily, or 1,500 mg per day, within the reduced maximum of 2,000 mg daily for patients over 80. Tramadol, the only acute analgesic prescribed at discharge, has significant limitations in this patient. It is listed in the 2023 Beers criteria as potentially inappropriate due to the risk of central nervous system effects including sedation, confusion, and seizures, and its serotonergic properties create interaction risk with other medications. Moreover, the as-needed dosing strategy is fundamentally flawed for a nonverbal patient who cannot request pain medication. This is a structural problem that leads to systematic undertreatment. The team replaces the as-needed tramadol with a scheduled low-dose, short-course oral NSAID approach, ibuprofen 200 milligrams 3 times daily for 7 days with concurrent omeprazole for gastroprotection. Given that Elena has no documented renal insufficiency and the acute postoperative period requires stronger analgesia than acetaminophen alone, her kidney function labs are checked on day 1 and day 5 of the NSAID course. Topical diclofenac gel is applied to both knees twice daily for her chronic osteoarthritis pain, the first-line treatment for localized musculoskeletal pain with a side effect rate indistinguishable from placebo. This addresses the likely pre-existing pain source that Maria identified and that may have contributed to the behavioral changes and the fall itself. The hydrochlorothiazide is flagged for review with the attending physician. Thiazide diuretics can contribute to orthostatic hypotension and electrolyte imbalances that increase fall risk, and the combination with metoprolol further compounds this risk in a patient already at high fall risk due to dementia, osteoporosis, and now a hip fracture. Elena's rehabilitation goals are necessarily different from those of Margaret or Robert. For a patient with advanced dementia who was wheelchair dependent before the fracture, the realistic goals are to restore the ability to participate in assisted transfers, to maintain upper body and trunk strength sufficient for supported sitting, and to prevent complications of immobility including pressure injuries, contractures, and pneumonia. Following hip fracture, multidisciplinary rehabilitation, including occupational therapy, probably results in fewer poor outcomes, and interdisciplinary geriatric team rehabilitation increases both function and mobility. The physical therapist initiates gentle, graded mobilization, beginning with bed mobility exercises and progressing to seated edge-of-bed activities and then assisted standing transfers as tolerated. TENS is applied to the left hip region during therapy sessions to provide drug-free pain relief during movement. Conventional high-frequency TENS at 80 Hz, strong but comfortable intensity, 30-minute sessions. TENS is particularly valuable for Elena because it carries no drug interactions, no systemic effects, and no cognitive side effects advantages that are critical in a frail older adult already on multiple medications. The occupational therapist focuses on maintaining Elena's ability to participate in feeding with hand-over-hand assistance with adapted utensils and on positioning strategies that reduce hip and knee pain during seated activities. Pain assessment is integrated into every therapy session. The physical therapist documents pain ad scores before, during, and after mobilization to ensure that rehabilitation is proceeding within tolerable pain levels and that the analgesic regimen is adequate for activity-based pain. A pain ad score increase of 2 or more points during therapy triggers a pause, repositioning, and communication with the nursing team about potential analgesic adjustment. Elena's case also illustrates several cultural and linguistic challenges. Her Spanish language background means that any vocalizations she produces, which may be her only remaining communication, can only be correctly interpreted by Spanish-speaking staff or family members. A moan may not just be a moan, it may be a word or phrase that carries clinical information. The facility ensures that at least one Spanish-speaking staff member is assigned to Elena's care team on each shift, and that professional interpreter services are used for all clinical conversations with Maria. Maria's cultural background is explored respectfully. She shares that in her family, elders are cared for at home whenever possible, and she carries significant guilt about Elena's placement in a facility. She also expresses a preference for involving their parish priest in major care decisions, a request that the team accommodates by including the priest in a family care conference. These are not peripheral concerns. Cultural background influences pain expression, treatment preferences, and family decision-making, and culturally responsive care is a clinical competency. At 2 weeks post-surgery, Elena's pain ad scores have improved from 8 to 3 at rest and from 10 during repositioning to 5 during assisted transfers. She is no longer moaning at rest, her facial expression is relaxed when undisturbed, and she is eating approximately 75% of her meals, a significant improvement from the minimal intake at the start. She tolerates assisted transfers from bed to wheelchair with moderate guarding but without the rigid pulling away behavior observed initially. Maria reports that Elena seems more like herself and has resumed responding to familiar music and Maria's voice with occasional smiles. The short-course oral ibuprofen is discontinued at day 7 as planned, with continued topical diclofenac to both knees and the low back for chronic osteoarthritis management. Scheduled acetaminophen continues at 500 milligrams 3 times daily. The tramadol is not resumed. The nurse care manager documents a structured pain management plan that includes standing orders for pain ad assessment at minimum every shift and with each repositioning or therapy session. A clear protocol specifying that a pain ad score of 4 or higher at rest or 6 or higher during activity triggers reassessment and potential analgesic adjustment. Continued topical diclofenac for chronic osteoarthritis. Continued scheduled acetaminophen. TENS during physical therapy sessions. And monthly reassessment by the nurse-led pain team with documented pain ad trending. Elena's case highlights several principles that complement the lessons from the other two cases. First, pain in patients with advanced dementia is systematically under-recognized and under-treated when facilities rely on clinical judgment alone rather than standardized observational tools. The pain ad provided an objective, reproducible measure that guided treatment and documented response. Second, as-needed pain medication orders are structurally inadequate for nonverbal patients. Scheduled analgesic regimens with protocol-driven reassessment are essential. Third, behavioral changes in dementia patients' agitation, care resistance, sleep disruption, appetite loss should always trigger a pain assessment before being attributed to dementia progression, because unrecognized pain is a common and treatable cause of these behaviors. Fourth, pre-existing chronic pain conditions. Elena's bilateral knee and lumbar osteoarthritis may have been generating unrecognized pain for weeks or months before the acute event, and addressing these chronic sources with topical NSAIDs produced meaningful improvement in comfort and behavior. Fifth, the nurse-led pain team model is particularly valuable in long-term care settings, where physician presence is limited and nursing staff provide the majority of direct care. The nurse care manager's role in coordinating assessment, communicating with Maria through interpreter services, liaising with the rehabilitation team, and documenting a structured pain management protocol ensured continuity of care that might otherwise fragment across multiple shifts and providers. Sixth, cultural and linguistic competence is not optional. Elena's Spanish vocalizations were her only remaining communication channel, and failing to provide Spanish-speaking staff would have eliminated the team's ability to interpret potentially meaningful verbal cues. Finally, realistic, patient-centered rehabilitation goals focused on transferability, comfort, and quality of life rather than independent ambulation reflect the principle that exercise and rehabilitation programs should be tailored to the individual patient's capacity, condition, and goals. Together, the three case studies in this module span the full range of clinical complexity addressed in this course. A post-surgical patient with mild cognitive impairment and psychosocial risk factors in Margaret, a community-dwelling patient with chronic pain, opioid dependence, and fear avoidance behavior in Robert, and a long-term care resident with advanced dementia, language barriers, and systematic pain under treatment in Elena. Each case demonstrates that effective pain management requires the integration of pathophysiological understanding, adaptive assessment, evidence-based pharmacotherapy, individualized rehabilitation, psychological awareness, and coordinated team-based care, the core competencies that this course is designed to build. Thank you for completing this course on multidisciplinary pain management and assessment. The evidence is clear that no single treatment, provider, or discipline can address the full complexity of pain. By integrating the knowledge from all 7 content modules into your clinical practice, you are equipped to deliver safer, more effective, and more compassionate pain care for every patient you serve. We will now review the exam questions to solidify your understanding. For each question, I will read the question aloud, give you the correct answer, and then explain why that answer is correct. Let's get started. Question 1. Which process represents the critical turning point in the transition from acute to chronic pain, where spinal cord neurons become overly excitable and can amplify or generate pain signals even without ongoing tissue injury? The correct answer is central sensitization. Central sensitization is the process by which neurons in the spinal cord and brain undergo functional changes that make them hyperresponsive to incoming signals. When central sensitization occurs, the nervous system essentially turns up its own volume. Pain signals get amplified at the spinal cord level, and in some cases, the central nervous system begins generating pain signals on its own, even when the original tissue injury has healed. This is why central sensitization is considered the critical turning point. It marks the shift from pain that is driven by peripheral tissue damage to pain that is maintained by the nervous system itself. Once this process takes hold, treating the original injury site alone is no longer sufficient because the problem has moved upstream into the central nervous system. Understanding this mechanism is essential for clinicians because it explains why chronic pain persists long after tissues have healed and why a multidisciplinary approach targeting the nervous system is often necessary. Question 2. Which observational pain assessment tool has the broadest evidence base and is recommended by the American College of Surgeons for use in patients with advanced dementia who are unable to self report pain? The correct answer is the Pain Assessment in Advanced Dementia Scale, known as PAIN-AD. The PAIN-AD scale was specifically designed to assess pain in patients who cannot communicate their pain experience verbally. It evaluates 5 observable behavioral domains: breathing patterns independent of vocalization, negative vocalization, facial expression, body language, and consolability. Each domain is scored from 0 to 2, giving a total possible score of 0 to 10. What makes the PAIN-AD scale particularly valuable is its strong evidence base and its endorsement by major clinical bodies, including both the American College of Surgeons and the United Kingdom's national guidelines. In clinical practice, anytime a patient with advanced dementia or severe cognitive impairment cannot use a self-report tool like the numeric rating scale, clinicians need to rely on systematic behavioral observation. The PAIN-AD provides a standardized, validated way to do that, reducing the risk that pain in these vulnerable patients goes unrecognized and untreated. Question 3. For an older adult with localized knee osteoarthritis, which medication is recommended as the first-line treatment due to its favorable balance of efficacy and safety, including a side effect rate statistically indistinguishable from placebo? The correct answer is topical diclofenac gel. Topical nonsteroidal anti-inflammatory drugs, and topical diclofenac gel in particular, are recommended as first-line pharmacotherapy for localized musculoskeletal pain in older adults. The reason is straightforward. They deliver the anti-inflammatory medication directly to the affected joint while minimizing systemic absorption. This is critically important in older adults who are at elevated risk for the serious systemic side effects associated with oral NSAIDs, including gastrointestinal bleeding, cardiovascular events, and renal impairment. In pooled analyses, the side effect rate of topical NSAIDs was 4.3%, which was statistically indistinguishable from placebo at 4.6%. This remarkably favorable safety profile is why the American Geriatric Society specifically endorses topical NSAIDs as a preferred alternative to oral NSAIDs for localized conditions like knee osteoarthritis. Clinicians should consider topical diclofenac gel before reaching for oral analgesics, tramadol, or other systemic medications in this population. Question 4. According to the evidence reviewed in this course, which statement best characterizes the role of exercise therapy in chronic pain management? The correct answer is that exercise is more beneficial for improving function than for direct pain relief, and programs should be tailored to the individual patient. This finding comes from a comprehensive evidence review of 21 Cochrane reviews, which represents a very large body of synthesized research. The review found strong evidence with a small effect size that exercise improves physical function in people with chronic pain. However, the evidence for direct pain relief was conflicting and also showed only a small effect. This distinction matters enormously for how clinicians counsel their patients. If a patient expects that exercise will eliminate their pain, they may become discouraged and stop. But if they understand that the primary benefit is improved function, better mobility, greater independence, and enhanced quality of life, they are more likely to stay engaged with the program. Equally important is the finding that no single exercise type was clearly superior to any other. This means clinicians should tailor exercise programs to the individual patient's preferences, abilities, and clinical presentation, rather than prescribing a one-size-fits-all approach. Question 5. Which psychological factor has been identified as a modifiable mediator that, when reduced through targeted treatment, translates into improvements in physical function and represents the clearest indication for combined physical and psychological intervention? The correct answer is pain catastrophizing. Pain catastrophizing is a cognitive emotional response pattern characterized by 3 key components: rumination, which is the inability to stop thinking about the pain; magnification, which is exaggerating the threat value of the pain; and helplessness, which is the belief that nothing can be done to manage it. Research has established that pain catastrophizing is not simply a byproduct of having pain. It is a modifiable mediator, meaning it can be directly targeted and reduced through psychological interventions such as cognitive behavioral therapy. When catastrophizing decreases, patients experience measurable improvements in physical function. This is a critical finding for clinical practice because it identifies a specific subgroup of patients, those with elevated pain catastrophizing, who have the clearest indication for combined physical and psychological treatment. Screening for catastrophizing helps clinicians identify who is most likely to benefit from an integrated approach rather than physical treatment alone. Question 6. According to the 2025 Lancet Neurology Systematic Review, high-frequency repetitive transcranial magnetic stimulation, or RTMS, targeting the motor cortex, is positioned as which level of therapy for neuropathic pain? The correct answer is third-line therapy. The 2025 Lancet Neurology Review placed high-frequency motor cortex RTMS at the third-line level in the treatment algorithm for neuropathic pain. This positioning reflects several practical and evidential considerations. First, the certainty of evidence supporting RTMS, while positive, remains limited compared to first-line options such as gabapentinoids, serotonin norepinephrine reuptake inhibitors, and tricyclic antidepressants. Second, RTMS has significant access barriers. The equipment is expensive, it is available only at specialized centers, and treatment requires multiple clinic visits over a course of weeks. These factors make it impractical as an early intervention for most patients. However, it is important to recognize that RTMS does have an established place in the treatment algorithm. It is not purely experimental. For patients who have not responded adequately to first-line and second-line therapies, RTMS represents a viable non-invasive option with evidence of benefit. Question 7. In the stepped care pain management model described in this course, which components are included at the foundation level, step 1, for all patients? The correct answer is validated pain assessment, patient education, activity counseling, and topical medications as indicated. The stepped care model is designed so that every patient, regardless of their pain condition or complexity, receives a solid foundation of care before more intensive interventions are added. Step 1 represents this universal foundation. Validated pain assessment ensures that clinicians are using evidence-based tools to accurately characterize the patient's pain experience across multiple domains. Patient education provides the knowledge patients need to understand their condition and engage actively in their own care. Activity counseling promotes safe, appropriate physical activity from the outset. And topical medications, when indicated, offer a low-risk pharmacologic option. These components are not just preliminary steps to get through before the real treatment begins. They are essential, evidence-based interventions in their own right. Higher steps in the model, such as structured exercise therapy, oral medications, formal interdisciplinary collaboration, and advanced interventions like neuromodulation, are added only when these foundational measures are insufficient. Question 8. For comprehensive assessment of chronic pain, which set of core outcome domains is recommended by international consensus? The correct answer is pain intensity, pain interference, physical function, psychological well-being, and patient global impression of change. International consensus has established that chronic pain is a multidimensional experience that cannot be captured by any single measure. Pain intensity, typically measured with a numeric rating scale, tells you how much the patient hurts, but it does not tell you how pain is affecting their life. Pain interference, assessed with tools like the Brief Pain Inventory or PROMIS instruments, captures how pain disrupts daily activities, work, and relationships. Physical function, measured with condition-specific tools such as the Oswestry Disability Index or the Roland-Morris Disability Questionnaire, tracks the patient's functional capacity. Psychological well-being, screened with instruments like the PHQ-2 or PHQ-9 for depression and the GAD-2 for anxiety, identifies the emotional burden of pain. And patient global impression of change captures the patient's own overall sense of whether they are getting better or worse. Together, these domains provide a comprehensive picture that supports clinical decision-making and meaningful outcome tracking. Question 9. What was the primary finding of the landmark-based trial regarding opioid versus non-opioid therapy for chronic back pain or hip and knee osteoarthritis over 12 months? The correct answer is that opioid therapy was not superior to non-opioid therapy for pain-related function and was associated with more side effects. The Strategies for Prescribing Analgesics Comparative Effectiveness Trial, known as the SPACE trial, was a 12-month randomized clinical trial that directly compared opioid therapy to non-opioid medication strategies for chronic back pain and hip or knee osteoarthritis. This was a landmark study because it provided high-quality, head-to-head evidence on a question of enormous clinical importance. The results were clear. Patients randomized to opioid therapy did not experience better pain-related function compared to those who received non-opioid alternatives. Moreover, the opioid group experienced significantly more medication-related side effects. These findings have been widely cited in clinical guidelines and have reinforced the evidence-based position that opioids should not be used as routine, first-line therapy for common chronic pain conditions such as low back pain and osteoarthritis. Non-opioid approaches offer equivalent functional outcomes with fewer adverse effects. Question 10. According to the 2025 meta-analysis of perioperative psychological interventions, which finding regarding pain education and psychotherapy was critically important for clinical program design? The correct answer is that perioperative education alone was ineffective, while active psychotherapy, such as cognitive behavioral therapy, showed significant benefit for reducing chronic postsurgical pain. This finding from the 2025 meta analysis carries major implications for how surgical programs design their perioperative care pathways. Many programs rely on informational handouts, educational brochures, or brief educational sessions to prepare patients psychologically for surgery. The meta analysis demonstrated that this passive, information only approach does not reduce the incidence of chronic postsurgical pain. In contrast, active psychotherapy interventions, including cognitive behavioral therapy, relaxation therapy, or a combination of both, showed statistically significant benefit. The key difference is engagement. Active psychotherapy teaches patients specific coping skills and requires them to practice those skills rather than simply absorbing information. For clinical program designers, this means that if the goal is to reduce chronic postsurgical pain, programs must invest in structured psychological interventions that actively engage patients in learning and practicing coping strategies before and after surgery. Informational materials alone are simply not enough. That concludes our exam review. I encourage you to revisit any questions you found challenging and to focus on understanding the underlying clinical reasoning, not just memorizing the correct answers. Good luck on your exam!